You know me, I'm a faculty member here at the Fred Hutch University of Washington and Seattle Cancer Care Alliance campus, a clinical investigator. I've research colleagues in the laboratory, and of course, I'm a provider that sees kidney cancer patients. And I'm delighted to welcome you to our 6th Kidney Cancer Patient and Caregiver Educational Symposium. We started this back in 2015 and have had annual events until last year in the setting of the pandemic. We skipped 2020, but we're thrilled to be back this year, of course, in a virtual format on a Zoom platform that I think we're all now becoming very familiar with. A couple of announcements. I just wanted everyone to be aware this meeting will be recorded. If you've seen the agenda, we do have a scheduled break about 11 o'clock. So if you're feeling like you need to step away, we will take a pause briefly to allow people to stretch their legs and reset. During the sessions, I invite the audience to submit questions with the Q&A function in your Zoom browser window. And we will try as best we can for time, pose your questions to the speakers as we go. We do have a session scheduled at the very end where Dr. Gore and I will be available to field questions as people have. Our speakers are invited to stay, but I think many of them have obligations and won't be able to stay till the very end. So I encourage you to submit your questions during the individual talks. If you wait to the end, the person that you were hoping to reach out to may be gone. There will be a request to provide your feedback presented during the session in the Q&A function, but also sent to you by an email follow-up. So I hope that you send your comments. And in particular, we're always thrilled to have people submit to us requests for other topics that we can focus on in future years. And lastly, I should not forget to thank the Seattle Cancer Care Alliance, the Strategic Network Outreach and Education Program for supporting this educational program. And in particular, I want to recognize Ritu Shriyan, who's the event manager that has brought this to life and done all the doing for today's program. So I'm so thankful for Ritu's hard work. So at this point, I want to turn the program over to my co-chair, Dr. John Gore. Many of you, I'm sure, are familiar with Dr. Gore and may very well be his patient. He's a professor on our campus in the Department of Urology, also an adjunct associate professor in Department of Surgery. He's the oncology lead for the urology group on our campus, and he and I co-staff the Kidney Cancer Multi-Specialty Clinic on our campus, some of you may be familiar with. So John, thank you for being here with us and participating, and take it away.
Thank you so much, Scott. It's really great to see the number of participants we have so far joining the Zoom. It's always a pleasure to do this meeting with Dr. Tykodi. It's really great to connect with patients old and new, and I'm always excited to present to you sort of our latest year's program in which we try to cover a lot of contemporary topics, what's new in kidney cancer, but also what are some of the adjuncts to kidney cancer care that you often tell us are very important to you. This is our agenda for today. I think, with this symposium, one of the things that's really accelerated the benefit of this symposium is our partnership with our local and national advocacy organizations. We would like to start with a couple of presentations. First, Bryan Lewis, the president and co-founder of KidneyCAN, has graciously agreed to join us. KidneyCAN, like many advocacy organizations, is a grassroots, patient-organized, patient-created advocacy organization that focuses a lot of energy and effort on advocacy, but also, toward this overarching goal of advancing cures for kidney cancer, devotes effort to supporting research in kidney cancer, as well as supporting patients navigating things like access to clinical trials and access to care. So Bryan, thank you so much for joining us, and we're looking forward to your talk.
Great. Thank you, Dr. Gore. Thank you also, Dr. Tykodi. It's a great pleasure to be here. Also honored to be on the panel with Monty Powell and others at Seattle Cancer Care Alliance. I'm going to do my best to try to share a screen here. I hope I can do that. Let's see if I can. Hopefully, maybe someone give me a thumbs up if I'm successful. Is that a share? Am I sharing now? I hope. Thumbs up.
Yes.
Yes. Great. Hi. Let me see if I can move us forward here. Bear with me 1 second. So let's see, does this move me forward? No. Sorry. My apologies. I don't know. Thought I was moving forward, but I'm not. Give me 1 second here. It's not doing it. Okay, here we go. Sorry about that delay. Again, my name is Bryan Lewis. I'm the president of KidneyCAN and a co-founder. I'm also a husband and father and a kidney cancer survivor from 2007. This is a picture of Dr. Gennady Brodslavsky, who was my surgeon at the NIH when I lived in Washington, D.C. My disclosures, KidneyCAN has a number of supporters in the pharmaceutical industry to help us do patient advocacy work, as well as propelling research. I'm also a patient advocacy representative with the NCCN guideline panel, as well as the KCRP Consortium Development Award. I'm also on the board of the IKCC and a lobbyist. Let's see. So today's topic's real fast. I want to talk briefly about our mission at KidneyCAN and also how we support patients and ultimately accelerate cures. So the genesis of KidneyCAN, I lived in Washington, D.C. As I said, I was a kidney cancer patient at the NIH. After going back to work, I lived on Capitol Hill about 11 blocks from the House and Senate. A friend of mine told me, Bryan, you're not supposed to be here. You got to give back. So I started going up to the House and Senate and talking to different offices. After 100 and so plus meetings and over a couple of years, had a very fortuitous meeting with the Congresswoman Nita Lowey from New York, and she was on the Appropriations Committee. Her nephew was diagnosed with kidney cancer, and I had met with them and with Congresswoman Lowey, and through some efforts of the ACKC and other advocates, we had been up on the Hill enough that they called me in and said, let's put some language in to our defense appropriations bill for some funding, some dedicated funding for kidney cancer research. Along that time, I met with Ralph and Brendan Knapp, who were doing some fundraising out of Virginia Beach, and we formed KidneyCAN in just a couple of years ago. So KidneyCAN's mission is to accelerate cures. And if you look at this through sort of a lens of a circle, you can see that what we're trying to do is we're trying to raise awareness of kidney cancer. We're doing that through our advocacy efforts, primarily in Washington, D.C. and elsewhere. And that advocacy efforts has resulted in funding, and the funding that's been dedicated for kidney cancer through a grant process to young and experienced researchers is to fund new and high risk, high reward ideas in kidney cancer. And that ultimately is going to lead us back someday to more cures. And so the way we do things at KidneyCAN is we break it down into sort of three buckets: advocacy, patient education and support, and propelling research. And so on the patient education and support, and I've got to pause here for a moment, our website is going through a rebranding / upgrade. And so if you're going to kidneycan.org, you have to go to www.kidneycan.org today until the transition takes place. But we have a patient resource center there that's going to be built out to include sort of newly diagnosed information, how to build a care team, other sort of basic information. We also started this year doing town halls. When we went to the video sort of landscape that we were all in, we decided to try to reach out to experts and see if they could share with the patient community directly. We did one early on after ASCO GU with Tony Chmura and Bryan and others. And then we did one with Dr. Uzo out of Fox Chase and Tony Chmura, and also had patients dial in from around the country, and hope to continue that into the new year. Also, we have a great partnership with the National Kidney Foundation. We do Facebook Live programming. These can also be found out on the web on the NKF's YouTube station, and as well as ours. Just on different issues around protecting your kidneys, nutrition, other matters that impact the kidney cancer community. But one of our best partnerships is with Smart Patients. Many of you may know the online community of Smart Patients, a great forum to air out, to discuss, to probe for questions and answers that you don't have at your fingertips. A great community there, Smart Patients. If you haven't heard about it, take a look. But shifting now to the advocacy bucket, how does kidney cancer research really happen? And we all know it takes people, and they do everything. Folks in Seattle are doing some of this kind of research with test tubes and mouse models and blood tests and biomarker testing. But all of this figures into the process of getting approvals for drugs. And you can see the new drugs from basic research over on the left of the arrow, all the way over to pre-INDs, can take a number of years and millions of dollars. And so that's one of KidneyCAN's efforts around advocacy, is to say, listen, kidney cancer, if you look over here on the far right at 13 grants, according to the American Cancer Society, you look over on the left, breast cancer got 162 grants. We need to be more active in this space, getting research grants. And so what we've done is we've tried to take this to the Hill, to Capitol Hill. We've reached out to multiple organizations, the KCA, Curate, Judy Nicholson Foundation, a number of the VHL Alliance, and we're all partnering and trying to bring our resources and our people together. And KidneyCAN provides sort of the skeleton or backbone for these efforts. And we're going to be having a district days in just a few weeks in August 9th and 10th. If you haven't heard about it or haven't signed up, I got to put in a plug for that. And advocacy does work. In 2016, we had $0 dedicated federal funding for kidney cancer research. Through the years, the last several years, through the efforts of our advocacy, we're now up to $50 million that was appropriated this year for kidney cancer research specifically. And we're now in the process of defending that $50 million. It's an annual appropriation. You can learn more about that if you join us at District Days. So what does this mean? So what? So you've raised all this money. What is that going to do? Well, we decided that we needed to help take these funds and help the people that had those funds, and to propel research, we wanted to bring those people together. So KidneyCAN has created a research summit. We call it the KCRS. It's going to be held in October. It was held 2 years ago live in Philadelphia in 2019, where we brought about 140 of the top thought leaders in kidney cancer community together to talk and to share about their research and the grants that they had been funded under. It was the first time that we really had the basic and translational scientists, some of them in the same room, talking about these issues. And so we're fortunate to have co-chairs of Tony Schwery and Hans Hammers. We're starting abstracts this year for the first time. Monty's on this call today. We got 22 abstract submissions, so we're excited about that. The grant funding process also, led ultimately to Dr. Bill Kalin, William Kalin at Dana-Farber, Boston, Harvard, to win the Nobel Prize. And his VHL research is, I guess, one of the cornerstones of some of the breakthroughs in kidney cancer therapeutics these days. And so we're making progress as an organization and as a community. We started at zero. We're at 135 million and growing. We've got a grassroots army of now 1,000, and we're hoping to increase that. Maybe you all could be a part of that. We've raised $1 million through local efforts. We've led the first ever grassroots funded clinical trial. And we're going to hold this third KCRS in a couple of months. But we still have a lot of work to do. There's 76,000 new diagnoses every year. 14,000 people are dying. That's unacceptable. And so there's funding gaps. There's a lack of awareness. You can see that the survival rate out 5 years is not anywhere near what we need it to be. So we've got a lot of work to do. We could use your help. So here's my plug real quick. KidneyCAN's a nonprofit organization with the mission of putting an end to kidney cancer. We want to accelerate a cure, and we do that by focusing on advocacy, research, and patient education. Advocacy Day is our attempt to bring people from across the country, a small grassroots army, if you will, of kidney cancer stakeholders, and we bring them together, we train them, and we talk about the issues, and we all go up to Capitol Hill and meet with our elected representatives.
What we want to do is not only just raise awareness, but raise the funds for research.
It is an opportunity for someone to, at a higher impact, talk with congressmen, senators, and their staff in regards to funding for cancer research, specifically kidney cancer research.
While this year will look different as we connect via Zoom with our elected representatives, the mission remains the same: to engage and educate policymakers on the needs and the urgency around kidney cancer research funding.
I'm really looking forward, once again, hoping to make an impact in research funding for kidney cancer, and this is one way that I can contribute.
We have found that these days have been very productive in getting the attention of Congress.
We're advocating for an increased funding at the NIH, the National Institutes of Health, as well as through the KCRP, the Kidney Cancer Research Program.
The advocacy has paid off. We got involved and helped that line item grow, and we hope it continues to grow in terms of the dollars dedicated specifically to kidney cancer research.
No experience necessary. That's our tagline. We give an entire toolkit to the advocates so they're ready to go. And it even has a script if they want to use it. We put some scientific information in there that's not real in-depth. We give a lot of facts and figures, and we give some do's and don'ts.
These people are wonderful, and they help you through everything. And we need you.
Your voice counts. Your story is important. We hear repeatedly the congressional offices, everybody's touched by cancer in this country. And so you can make a connection, tell your story, tell what's going on, and advocate for our position.
So much more work needs done. Somebody's got to do it. The more voices, the more awareness, the brighter the future.
Great. Thank you very much. Really appreciate your time. You can find us on social media. I just want to last plug, the folks in Washington, you have some senior elected representatives with Senator Patty Murray, Senator Maria Cantwell, both Senator Murray, very influential in health policy and health appropriations. Congresswoman Del Benny, Kilmer, let's see, there's Kathy Rogers, Adam Smith. You've got a lot of folks in the Washington area that we could really use your voice on the ground virtually in August and throughout the year. So if you haven't had a chance, please consider signing up. And with that, I'll turn back over the screen. I hope I have stopped my share.
You have. That was perfect. Thank you so much. We have partnered from the get-go with this education event with Art and Julie Chmura, who run our local SCCA Seattle kidney cancer and bladder cancer support group. And we're delighted that they are able to join us again this morning. And so I'd like to hand the presentation over to Art and Julie.
Hi there. Oh, wow.
I think they're hearing you.
Yeah. So what do I do?
Just speak.
Okay. I'm Julie Chmura, and I've been a cancer survivor since 2000. I was diagnosed with tumors in both kidneys. Actually, I had 2 tumors in one and one in the other. And of course, I was absolutely terrified, and because my father had died of kidney cancer. But with the help of my husband, who found an article in the newspaper, he found a support group that was coming from Washington, D.C., I believe, was it?
Yes.
And so we attended that, and there were a few people there that had also had kidney cancer, and I felt, my God, there's somebody else out there. I'm not alone. And eventually, after a couple more sessions with this kidney cancer support group from DC, we were talked into hosting one here. There had been nothing on the West Coast at all. And I think we were the first ones, at least that I know of. So because I was concerned about how many people were out there with kidney cancer, the meeting started at Seattle Cancer Care. And Dr. John Thompson was our mentor. And he started the whole thing off, and he gave us a room to host the meetings. And it just kind of went from there. We have meetings probably
4 times a year.
4 or 5 times a year. We have speakers occasionally. Some of these doctors have been speakers, and we also have researchers and so on. And it's a wonderful group. We get up to 18, 20 people coming, except now during this COVID thing. Can't do that, but this is wonderful. Zoom is just awesome. And we're going to try something like that until this pandemic thing settles. One of the great things about the support group is that we get people to talk to each other about their cancers and their treatments and how they feel, and just kind of interacting with each other. And it really helps the people, each other. I've been not cancer free, but since I think 2003, I haven't had a recurrence, which is pretty good for having tumors in both kidneys. What else did we want to say?
Well, basically our format is Julie has made contacts with people all up and down Oregon, Washington, sometimes Idaho. We had some British Columbia. We've had people from all over. So it's not just a Seattle group, it's a Northwest group. And our process, Julie sends out an email notifying everybody that she has on her extensive list when we're going to meet. That's 4 or 5 times a year on a Saturday afternoon at 1 o'clock in the afternoon. People come by ferry boats. Some people drive down from Bellingham. We have a regular group that comes up from Portland. And I start the meeting off with something that I typically picked up from the web on, it used to be called KidneyCAN, and now it's Smart Patients. And I put it into a presentation mode just to kind of kick off the meeting, give format. And then we move into the part that really counts, where the patients and caregivers are talking to each other. Don't forget, caregivers have a stake in this as well. And typically, I've been trained in how to run meetings better and keep things moving after 41 years at Boeing, most of which I was a manager. And we do manage to keep the meeting moving, get a lot of voices heard, a lot of people pick up information, and they come in kind of terrified, they walk out feeling better. That's really the value of what we've been doing for the last 17 years. And we do it on our own. We bring some small snacks and some bottled water and things like that. And SCCA has been good enough to give us a good location where we can put things up on the board and show presentation material. And it has worked out actually quite well. And I think we've helped people. We've seen some people end their journey. We've attended a number of funerals, but it's all been to the good. And from what Julie started, she was looking for hope. And this is part of what helped to give her hope. I guess that's the story. Anything more, Julie?
I don't think so. I'm still alive.
I think hope and reassurance are incredibly valuable outcomes, right? I often, when visiting with patients, say that reassurance is sometimes the most important outcome of our visit. A cancer diagnosis is incredibly anxiety provoking. It instills in a lot of us, no matter how much we know about cancer, no matter how enabled we feel with information, it's a challenging thing to be a patient. And so sometimes reassurance is more important than some of the therapies that we can offer. So thank you both, not only for being here today, but for maintaining and sustaining a really awesome support group. And I love always getting your updates. So we've been doing this for 6 years. In those 6 years, we have always tried to bring in an expert from the outside kidney cancer world. And I think we've been trying for 4 years to have Dr. Monty Powell be our keynote speaker. It's always been difficult to connect our schedules, busy people being busy. But I couldn't be more excited to get to introduce our keynote speaker today, Dr. Sumanta or Monty Pal. It's interesting that, we always say that this is a small world that we live in, but it really is. Dr. Pal is an internationally recognized leader in genitourinary cancers, not just kidney cancer, but bladder cancer and prostate cancer as well. He's co-director of City Hope's kidney cancer program. He's the head of the kidney and bladder cancer disease teams at that institution. But I also first met Dr. Pal almost exactly 20 years ago in July 2001, when I was a surgery intern and Monty was starting his clinical rotations as a medical student. What I didn't know at the time is that Monty was only 19 years old. So after completing his residency training at UCLA, he completed his fellowship at City of Hope, and he's been on the faculty there since 2009. Over that span, so in the last 12 years, he has published more than 300 scientific articles. These have been featured in leading journals in cancer research, including a recent landmark paper in Lancet on the PAPMET trial for patients with metastatic papillary renal cell carcinoma. Dr. Pal holds patents for new drugs currently under development in prostate cancer. He maintains a large portfolio of clinical trials for urologic cancer research. He is immensely collaborative, both at his own institution as well as nationally and internationally. He is robustly grant funded, but he is also highly regarded in a role I know he takes seriously, and that is as a mentor to aspiring medical students, residents, fellows, and junior faculty. He has received numerous honors for his talents, including for mentorship, and very prominently was named one of the 40 under 40 leaders in cancer care. We are incredibly lucky to learn from you today, Dr. Pal.
Dr. Gore, that has to be one of the nicest introductions I've ever received. Thank you so much. And truly, it's such an honor to be here. It's amazing to, kind of think back to those early days in training, and, you just never know how, careers is going to pan out. And it's just wonderful to be able to still work side by side with you. I'm looking at the date here, 2 decades later. Pretty wild. So thank you again to you and Dr. Tykodi and the entire gang at SCCA for having me. I wanted to take a very different approach to my talk today. I just want to do a quick check and make sure you guys can see my title slide here. Am I sharing the right screen? Perfect. Thanks a lot, Scott. And so, I wanted to take a very different approach. Oftentimes I've given patient updates like this. Art and Julie were reminding me that they'd seen me at some previous forums, similar to this one. And what I'll do is I'll just take some of the conference slides and, try to rehash what's been done at recent meetings. But I thought I'd take a very different approach today. I'm going to really be mindful of the time because I want this to be very interactive. It was suggested that I leave about 15 minutes towards the end for a discussion, but please interrupt me and stop me along the way if there's any questions I can answer. And I actually wanted to take you through exactly what I kind of do when I'm meeting with a patient for the first time with kidney cancer. I tend to be a very visual learner. And, this kind of goes back to the way that I learned organic chemistry in college and, other subject matter, but I've always really relied a lot on using my hands and drawing quite a bit. In the clinic with patients, I always use a pen and a paper. And, my wife recently got me a little drawing pad for my computer, so I was able to sketch some of these little drawings out that mimic what I do in the clinic on a day-to-day basis. Again, I think one of the best places to start is by describing what I do as a medical oncologist. I, generally speaking, see patients with more advanced disease that may change over the course of time. So when we talk about kidney cancer, there's a spectrum of stages 1 through 4. 4 generally implies that, the cat's out of the bag and the kidney cancer has migrated to other organs, be it the lungs or the liver or the bones. And those patients are the ones that typically fall in my domain. And that's what really the counseling that you're going to hear today is directed towards. I did see a patient. I had a clinic late yesterday. The last patient that I saw was this lovely lady, who had a recurrence of a very small, 5 millimeter tumor within the kidney. And those are the sorts of cases where I probably have a very limited array of input in most cases. And so, certainly if there's questions that are more directed towards the urologist that pertain to surgery, I'll probably turn it over to Dr. Gore, who's really an expert there. So with all that really extensive background, and I actually saw this sort of pop up in the chat already, I wanted to just quickly describe the types of renal cell carcinoma. So, if you're meeting with your oncologist for the first time, one of the things that I really recommend you come armed to the appointment with, and your oncologist should, be able to access this in most cases ahead of time, is your pathology report. And this is one of the things that you'll see front and center on your pathology report. This delineates the different types of renal cell carcinoma. And I'm going to use a term here that you'll see demarcated on your pathology report. It's actually, what we would use to allocate the type of therapy you receive, and that's called histology. So histology simply refers to the way that these tumors look under the microscope. I oftentimes will draw out this pie chart at the start to explain that there's multiple types of kidney cancer. We often refer to it as just being, a single entity in our discussions, but in fact, it's a very, very heterogeneous disease. The most common type of kidney cancer is clear cell kidney cancer, which you see indicated here in the yellow. But there's also rarer subtypes that I think are incredibly important for us to focus on. Papillary kidney cancer is one of my areas of passion, as Dr. Gore had alluded to. And this is a smaller cut of that pie. It's about 10 to 15% of cases. Chromophobe is about 5% of cases. And then in purple here, I've listed, that other set of subtypes. This includes things that, again, you're going to see this on your pathology report. XP11-2 or translocation kidney cancer, collecting duct kidney cancer, medullary kidney cancer. I just wanted to take a moment to, discuss some of these. I think that Dr. Tykodi, Dr. Gore, and we probably see an overrepresentation of everything here in green and blue and purple, since we're at academic centers. And, I think some of these patients, really tend to come to us for some of that specific expertise and how to manage these exquisitely rare conditions. But, I'll focus on the fact that each one of these tumor types is driven by, what we believe to be an entirely different biology. So what's interesting is that if you look at the purple slice over here, I've delineated there two tumor types that are easier to read than the first, collecting duct and medullary. What's really interesting is these behave, at least, in terms of clinical practice, in many cases, a lot like bladder cancer. So this is one of those rare scenarios where we might actually talk about treating kidney cancer with chemotherapy. In the other subtypes, that's pretty much unheard of. And in the other subtypes, you'll see a mix of what I'll describe in a moment as being targeted therapy, immunotherapy. So I think that when you're sitting down with your oncologist, getting that pathology report and really deciphering, what type of cancer you're dealing with is really critical. I see that Terry and Don have a good question around combo or single drug treatment, a second line treatment after IL-2. So I'm going to see if I can tackle that in just a second as we jump into treatment. I'm monitoring the Q&A as we go through this. I'm going to advance to the next slide here. So this is an important schematic that I usually like to draw out in the clinic. And to me, this really delineates a lot of hope. Targeted therapy refers to a process in which we actually hit the specific targets that we know drive kidney cancer. What you see here in yellow is probably one of the most classic discoveries in kidney cancer. I'm not going to focus too much on the names here and what they really entail from a biology standpoint, but this particular protein, and these are all proteins sitting at the surface of the kidney cancer cell called VEGFR, is really critical in driving, I would say, the vast majority of kidney cancers out there. So just to back up one step, when you're looking at this diagram, and Dr. Tykodi, Julie, you guys can see my pointer, right? Can you see my pointer on the screen? Yeah, okay, perfect. So this is meant to be blood out here. This is meant to be the inside of the kidney cancer cell. This is the nucleus where the DNA sits. And these three entities, four entities, I should say, are actually proteins that are really key in driving kidney cancer growth. So the one in yellow, again, is VEGFR. This is one of the proteins that we think is really, really key in terms of driving kidney cancer. So how does this work? Well, you have these proteins that are floating around in the bloodstream. And I've delineated one here as sort of a pizza slice. When this pizza slice binds to this protein, it actually triggers this cascade of events. It activates this protein here in light purple or pink called mTOR. And then that actually sends the signal to the inside of the cancer cells that tells the DNA, let's split and grow and divide. Okay. But kidney cancer cells are smart. So they've actually developed these mechanisms to bypass this. So instead of leaning on this yellow protein and causing this chain reaction to grow and divide, they can actually lean on these proteins here that are listed in purple called MET or in blue called FGFR. So, before, and this is back when, Dr. Gore and I were in medical school, these were just being discovered. These were entities that we knew about, but these were not entities, unfortunately, that we could actually treat. One of the really amazing things is that now we have drugs that we can treat them with. So just a little bit of nomenclature here. When I have these arrows in black, that means you're having a process that drives the kidney cancer. When I have these lines in red with a little straight line at the edge here, these are drugs that we've come up with that can block it. So the real big advance is that, again, when Dr. Gore and I were in medical school, and I'm really, sort of dating us, with this diagram here, but all we knew about were the existence of some of these proteins. Now, 2 decades later, we can actually drug these proteins, if you will, and treat them with agents that can block them. So, some of the drugs that you may hear about from day to day, and what's interesting about this is I've listed a lot of drugs here, but this is by no means an exhaustive list. We have many others that are in development right now. You can actually drug these individual proteins. Two of the drugs you may have heard about are called axitinib and sunitinib. I'm referring to these by their generic names as opposed to their trade names. You may have heard of their trade names as well. We've actually gotten smart, and now we're able to drug 2 proteins at the same time. So we actually have a drug called cabozantinib that can not just block VEGFR, but can also block MET2. And then I kind of scribbled this in the corner here. I ran out of space, but we've got a drug called lenvatinib that can block FGFR and VEGFR at the same time. So this is kind of cool, because if you've got a smart kidney cancer cell that is just exploiting, that is not just exploiting this yellow protein, but using the purple one and the blue one too, we can use some of these drugs to hit 2 receptors at the same time. And then we also have a drug that I would say is probably waning in terms of its use, but still has a role in many of my patients with kidney cancer, called everolimus. So that's listed down here, and you can actually block this messenger that ultimately tells the nucleus of the cell to start replicating DNA and causing the cell to divide. So, again, I'm monitoring the questions here, and I'm happy to answer any that come up along the way, but I'll keep moving in the meantime. This is the second or third diagram, I should say, that I draw out when I'm meeting a patient in the clinic for the first time with kidney cancer. And this really describes the general premise of immunotherapy. So, when we talk about immunotherapy, it's really critical to understand that immunotherapy really functions on the basis of utilizing and exploiting what are called T cells. So your body's immune system is constituted by a number of different immune cell types, one of them being called T cells. You may be familiar with conditions like HIV and AIDS, where, in that scenario, the T cells are just completely depleted and patients are, susceptible to infections and what have you. What's interesting in cancer is that these T cells are just asleep. They're just completely dormant. So when we talk about immunotherapy for kidney cancer, this isn't just relevant to kidney cancer nowadays, it's relevant to a number of cancer types, melanoma, lung cancer, and what have you. We're actually really talking about reactivating the T cell, waking it up and getting it to drive against the cancer cell. In you or in me, there's this degree of immune surveillance that's happening on a day-to-day basis. But in someone with active cancer, what you'll notice is that these T cells are just totally quiescent. So this was actually the subject of Nobel Prize that was issued 2 years ago for cancer, and this was actually the discovery of drugs and pathways that can actually reactivate that T cell. So there's 2 proteins that I think you're going to hear about in your reading on immune therapy for kidney cancer, and those are CTLA4 and PD-1. So if I had to, sort of recall 2 of the names from this slide over here, which has a number of words on it, I'd keep in mind CTLA4 and PD-1 here. When these proteins are not engaged, the cell is active, it's ready to roll. But when you're engaged over here, The problem is that it shuts down the T cells' activity. So we now have strategies that can block these. So we have drugs like nivolumab and pembrolizumab. Again, I'm using here the generic names, not the trade names. So you may have heard of them under different monikers, but basically we have proteins that can, sort of block from this side or block from this side. We have drugs that can actually block CTLA-4 like ipilimumab. And this whole process is really intended to turn the T cell back on. So, essentially, we've got targeted therapy, as I described on this slide, which blocks specific proteins at the kidney cancer cell surface and maybe in some of the surrounding cells. And then we've got these immune cells, which are usually dormant. They're just asleep in the context of kidney cancer. And we're really reactivating and turning them on through use of these various drugs. So one of our attendees asks, why are these T cells sleeping in the first place? It's a fantastic question. It's really because, of these proteins being engaged within this interaction over here. And again, you see that to, sort of a lesser extent in the context of patients or individuals without cancer. T cell function tends to be much more normal in that context. So good questions coming through. This is, one of those how it started, how it's going types of slides here, which I think is just remarkable. But this actually goes back to, beyond when I was in medical school, maybe back to just before I started college back in 1992. But Terry and Don had a question around interleukin-2. And specifically interleukin-2 is a drug that was developed back in the early 90s. This drug is really pretty impressive. It probably represents the first, sort of issue of immunotherapy in kidney cancer, but it works in a very simplistic way compared to the immunotherapy that I've described here. Basically, IL-2 sort of indiscriminately tells your immune system to turn on, to activate, and drives this very generalized immune response. So the side effect profile of interleukin-2 can be quite challenging, quite taxing. I'm not going to focus on it so much today because I would find that at many of our centers, we're not using it quite as often. But certainly I'd love to hear Dr. Tykodi and Dr. Gore's experience with that. Interleukin-2 requires 2 weeks of hospitalization. At a time, and basically it comes with potential cardiac side effects and other issues that make it challenging to give. And we've reserved it in the past for patients that really have a limited extent of disease and, a much better, I would say, protoplasm, if you will, individuals who are healthier, who lack certain comorbidities. Whereas the treatments that have been developed since then can be applied to a broader group of patients. So, moving forward in 2005, and this is what I had alluded to on that targeted therapy diagram, we started developing these so-called targeted therapies. I've described VEGF inhibitors here, and you can see, referring back to my initial diagram, that refers to the drugs that block this particular protein in yellow over here. In 2007, we saw the advent of mTOR inhibitors. So these are the drugs that block what you see in light purple or pink over here. And then we have, since that point in time, the advent of PD-1 inhibitors back in 2015. And I keep on referring back to my diagrams here, but you can see that those are the drugs that block this particular pathway in kidney cancer and reactivate the T cells through this mechanism. And then the really exciting stuff comes really, I would say, within the past 2 or 3 years, when now we're starting to combine these, right? So now we're starting to use targeted therapy in concert with immunotherapy. So we're taking the drugs from this slide over here, and we're combining it with the drugs on this slide over here. Or the other approach that I've highlighted is where we use a dual immune therapy approach, and we actually block both of these proteins simultaneously using a combination specifically of this drug ipilimumab and this drug nivolumab. So David Hume, and I hope you guys don't mind if I call out your names here, I can see that in the Q&A section, but Mr. Hume asks an excellent question, which is why not just use cabozantinib and lenvatinib in combination? Because it looks like you're nabbing these two proteins with cabozantinib. It looks like you're nabbing lenvatinib with this combination of proteins over here. Why not just double down on this? The challenge is that, Dr. Tykodi and I have been a part of a number of different trials over the years, and we see that, you know, when you really double down on hitting these receptors, you end up with a lot of overlapping toxicities. So we'll get to that a little bit later in my talk today. But both of these drugs, for instance, cause hypertension or high blood pressure. Both of these drugs cause diarrhea. You know, both of these drugs cause a phenomenon called hand-foot syndrome, right? So you run into these issues and you just reach a point where, you know, patients in broad terms can't tolerate. One experience that I'm quite familiar with is something that was published years ago, which blocks this bit of pizza over here with a drug called bevacizumab. And it combined it with sunitinib, which blocks the receptor, the VEGFR protein that you see down here where this piece of pizza fits. So, I mean, it makes sense logically, right? You block this piece of pizza, you block this protein, and boom, you know, you're doubling down on fighting the kidney cancer. But what we saw, which just can't handle. So brilliant question. That would be my perspective on it. Okay, so you know, again, usually, you know, in the past when I've done this talk, I've referred to slides and so forth. But this is actually something that I've done with my patients. I actually do this with a lot of my fellows and trainees in the clinic. I think that if you're approaching your physician about kidney cancer now in 2021, it's interesting to actually go through some of this recent history that I've outlined on this diagram and understand how these trials looking at combinations of targeted therapy and immune therapy or immune therapies together have evolved. And they're all on the basis, thankfully, and I think you can take some comfort in this, in trials that have involved many hundreds of patients. So I've kind of split this, you know, diagram into 4 over here. And one of the things that, you know, you can appreciate is that each one of these is an independent clinical trial. We call it a phase 3 clinical trial, which is the phase that leads to FDA approval, because you're taking a new regimen and comparing it against an existing standard, right? So each one of these is a phase 3 trial, and each one has a bare minimum 600 patients. So, you know, we've got a huge experience across all of these trials that really tells us about the safety and the effectiveness of these different combinations. Now, I know I'm leaning a lot on the slides that I presented previously. So again, if I can just remind you of the general principle, this is targeted therapy here, and then this is immunotherapy over here. So just to remind you, this particular trial over here is looking at an older drug called sunitinib. This was actually one of the first targeted drugs approved for kidney cancer back in 2005. And this was a huge milestone when it was approved. But keep in mind that all of the trials that you're looking at here use sunitinib as a comparator arm. So that actually makes it, I mean, we're technically not supposed to do this, but it makes it a little bit easier for me to look across these 4 studies and say, well, this drug performs this well against sunitinib, whereas this regimen performs this well against sunitinib. So it gives me some basis for comparison to estimate which of these regimens I should be using. So in the top left, just to remind you, is a combination of nivolumab and ipilimumab, which is 2 immune-based therapies. Those are blocking, you know, these pathways around the T cell, okay, against sunitinib. On the other hand, this trial over here is looking at cabozantinib, which is that targeted therapy that blocks 2 proteins in purple and yellow over here, combined with nivolumab, which is just blocking this portion of the T cell over here. Okay, so we've got cabozantinib plus nivolumab. Then we have a trial that looks at axitinib and pembrolizumab in combination. So remember, axitinib is blocking the yellow protein over here fairly specifically, okay? And pembrolizumab is blocking this particular protein sitting on the T cell surface, okay? And then we've got lenvatinib and pembrolizumab, which is blocking this blue protein and the yellow protein over here in combination with pembrolizumab, which is again blocking one side of the T cell. So immune therapy, targeted therapy plus immune therapy, targeted therapy plus immune therapy, and targeted therapy plus immune therapy. Just to be a purist, I've thrown in a little wrench over here, and this is really how the study was designed, but this particular trial also looked at an interesting targeted therapy combination of lenvatinib with everolimus in combination. This kind of gets to the question that Dave asked, because what we're doing with this combination is we're hitting this blue protein and the yellow protein with lenvatinib, and we're also hitting this pink protein with everolimus. So it is kind of like using 2 targeted therapies in combination. What I'll demonstrate to you is, you know, to Dave's question, that approach is probably not quite as effective. in case you guys are digging through the literature, and again, I think this is an incredible group of patients and caregivers and advocates. You're going to run across the titles of these studies. So I just wanted to delineate those over here. This is known as Checkmate 214. This is known as Checkmate 9ER. This is known as Keynote 426, and this is known as Clear over here. I just bear these studies in mind as we kind of go through this. Matthew's asking what's probably going to be my favorite question of the day today, which is a study that was presented at ASCO looking at probiotics in the context of immunotherapy. That was actually a study that one of my fellows presented. It was a study that we've been working on at City of Hope for the past couple of years. And so I'll get into that question as we go on here. But when you're looking at these trials, okay, I think the most important bar that we need to look at is whether or not, relative to the older generation of drugs like sunitinib, whether or not these agents improve survival, okay? Did they or did they not improve overall survival for our patients? And fortunately, and what's amazing to me is that the answer across all these 4 studies is yes, okay? So if you look at nivolumab and ipilimumab, if you look at axitinib and pembrolizumab, if you look at cabozantinib and nivolumab, and if you look at lenvatinib and pembrolizumab, compared to sunitinib, all these improve survival. This combination of lenvatinib and everolimus did not improve survival. Okay, so this makes it kind of easy right from the get-go to maybe X this out as a preferred frontline approach. So again, all these studies took patients that had gotten no prior treatment for stage 4 kidney cancer. If you've got newly diagnosed stage 4 kidney cancer, in most circumstances, I would say this probably isn't your best bet based on the data that I'm showing you here. Okay. I'm going to jump to the next slide over here, which asks the next important question, which is, did the regimen delay tumor growth relative to sunitinib? And this is important too. This is what's called, and you'll see this referred to in, if you're looking at the actual data presentations and abstracts, as something called progression-free survival. So overall survival is what I alluded to on this last slide over here, where you're looking at fundamentally how long patients lived, right? Progression-free survival indicates the delay in cancer growth. And what's phenomenal is that everything that I'm showing you on this slide, including this combination of targeted therapies, delayed tumor growth relative to sunitinib. So I think that that's really important. I think that that's an important finding. Another thing that I think is really critical is response rate. And I'm going to really kind of try to hone in on response rate a little bit, because this is an important distinguishing factor between all of these studies here. Response rate refers to how frequently you had significant shrinkage of your tumors, okay? And again, these are for patients with newly diagnosed metastatic disease. The question is, how frequently do you have significant decreases in the size of those tumors? And, the most logical response to that question is, well, what is significant, right? I mean, it really is kind of in the eye of the beholder. But what Dr. Tykodi, what Dr. Gore and I have done across studies, and this is true nationally, internationally, et cetera, is we've sort of set a bar for what significant is in this case. It's a bit arbitrary, but we call the response rate here a decrease in tumors cumulatively of 30% or more. So when Dr. Tykodi, when Dr. Gore put you on a research study, we're measuring your tumors at day 1, and we're picking a couple that we're going to follow over the course of time. And the response rate alludes to whether or not you have a shrinkage of 30% or more across those. So this is kind of an important distinguishing factor amongst these. With nivolumab and ipilimumab, the response rate is around, and I'll spell out the numbers here, but I don't necessarily want you to commit them to memory. Response rate here is around 45%. With these other regimens, it's somewhere in the ballpark of 55 to 60%. So there's reasons to use nivolumab outside of the response rate, but I would say that the response rate associated with these other regimens is a bit higher, okay? Now, what about quality of life? And this is something that and this is controversial. I think Dr. Tykodi will concede, Dr. Gore will concede that we're not great at understanding your quality of life as you're going through these drugs. That's not to say that we're not trying. You know, we're using these surveys, and many of you who have been on clinical trials will be familiar with these surveys that we give you at every single clinic visit. They're kind of tedious on many occasions, but we think that they might offer some sense of how you're doing in terms of the side effects that typically plague our kidney cancer patients: fatigue, diarrhea, nausea, etc. And when we administered these metrics, it's very clear that patients on nivolumab and ipilimumab really, have an excellent quality of life as they're going through treatment. And the real interesting thing about this regimen is that you start on the 2 drugs, but you actually morph into just one after a period of time. And so you get spared some of the potential side effects associated with targeted therapy. When we look across quality of life, we didn't see a significant improvement with this particular regimen over here. With this particular regimen in the bottom right, the answer is maybe quality of life is improved. And with this regimen in the top right, the answer is yes, quality of life did, see an improvement over the course of time. So again, this is controversial, but this is the data that we have. And ultimately, when patients are coming to see me, they're asking for sort of a definitive rationale, definitive logic for why I do what I do in the clinic. So to me, I think this is a reasonable justification for why these 2 at the top are some of the regimens that I tend to use in the first-line setting for kidney cancer. So, what else sort of guides my treatment from day to day? Well, here's the deal. What I've written in here are the reasons in red why I probably stay away from these regimens in my own clinical practice. Now, you may see your physician and they have a completely different but sound rationale for offering these therapies, but I urge you to challenge your doctor and say to them, why are you picking the regimen that you're picking aside from the others that are out there? And they should have a well thought out rationale for this. So what I would suggest is that quality of life is the reason that I tend to stay away from this particular regimen. I have some concerns around the dose that we're using of lenvatinib in this particular regimen over here. What's interesting is that we've been using cabozantinib, this particular drug here, for years at a much higher dose for patients who have been on first-line therapy and second-line therapy. We actually dropped the dose in the context of this study here, and I find that it's very well tolerated. As I showed you on the last slide, it seems to improve quality of life. So this tends to be one of my preferred approaches for patients in the frontline setting. And I also tend to use a lot of this regimen, nivolumab with ipilimumab. And I particularly think it's good in one scenario, which comes up a lot in clinic. I saw a patient last week who had a very large tumor that was intact within their kidney. They had multiple areas of spread in the lungs. And I thought to myself, this patient's symptomatic, needs to have their kidney out because they were having a lot of pain, bleeding from their kidney. Being on this regimen actually allows me to send that patient to surgery to have their kidney removed right away. Whereas if I put them on one of these other regimens that includes a targeted therapy, right? That's what's unique about this regimen. It's pure immunotherapy. If I put them on a regimen that entails targeted therapy, then we might run into issues with wound healing and so forth. A couple of other, caveats over here. I think that the other thing that's important to come armed to your clinician's office with is the question of what is my risk status? And I'm not, asking you to, sort of pressure the oncologist to tell you, about survival statistics and so forth. I think that's a very personal decision, but I do think that understanding your risk status is really key. And I'm not going to get too much into the weeds here on this, but this is how you calculate your risk. You get a point for each one of these characteristics over here. If it's been less than a year from when you were diagnosed with kidney cancer to when you need therapy for stage 4 disease. So let's say, you had your kidney surgery in March of this year, and now we're in July. That's less than a year, right? And if you identify, or if you're identified as having metastases or spread to other sites, you would get a point for this. On the other hand, if you had your kidney removed 10 years ago, and now you see that the cancer has spread to the lungs or other organs, you'd get a 0 for that, okay? And you want as few points as possible under the circumstances. This value, the KPS, is something you can ask your oncologist about. This is the functional status that we assign probably at every clinic visit to every patient that we see. This is our estimate of how functional you are in terms of your day-to-day well-being. Are you going to the grocery store? Are you able to make it to, your daughter's school events? Are you able to button your shirt? You know, those are the sorts of simple things that we use to assess your functional status. And then these 4 are things that, you know, you can probably pick off your MyChart, you know, or your patient portal, but look at your hemoglobin level, your calcium level, your neutrophils, and your platelets. These are different elements of the blood counts and your chemistries. But if you have high levels of these or a low level of hemoglobin, you get a point there. And basically, you know, so these are things you can ask your doctor about that I've listed in red here. The ones in green are things that you would refer to based on laboratory assessment. So, you know, I encourage all of you to take a look at this. And if you have no points, you get put into a favorable risk category. If you have 1 to 2, you fall into an intermediate risk category. And if you have 3 points, you fall into what we would term, and I hate this term, but it's termed a poor risk category. So take a look at, you know, your risk categorization. How does that play into treatments? Well, you know, I actually do not use this regimen for favorable risk disease because we just haven't seen as much benefit there in my perspective. Again, different clinicians have different perspectives of the data, but, you know, I really wanted to give you my shake on how I look at all these trials. So I think it's really critical that, you know, you look at this data set and in favorable risk disease, perhaps consider staying away from this regimen. Okay, so what's on the horizon? I swear to you, this is not, you know, pre-planned. This question from Matthew Peltz, who asked about this study that looked at immunotherapy in the gut microbiome, but this just happens to be my study, and I'm quite enthusiastic about it. But this particular study is exactly, I think, what you asked about, which is a trial that we did with a very small number of patients. And I really want to emphasize this, just 30 patients. Everything that I showed you on the previous slides had hundreds of patients. This is just 30. So we can't make any definitive determinations based on this. But I've been interested in the gut microbiome for years. So this is my, you know, my terrible sketch of the colon here in orange, okay? And my hypothesis is that what's going on in the gut, and this has been vetted by a number of really great scientific papers, what's going on in the gut can really trigger what's going on in the remainder of the body. It can really influence the body's immune system, and ergo, it can impact your response to immune therapy. So we did a study where we took this bacterium called CBM588. This is actually something that's commercially available in Japan. I do not encourage you to use this strategy at this point until we have it really vetted in larger clinical trials. But, you know, this is something that we gave to patients in combination with nivolumab and ipilimumab. Again, this is a pure immunotherapy regimen. We had 20 patients that got this combination. We had 9 patients that just got immune therapy by itself. Our thought was this particular bacteria makes it to the colon. It's a spore. Once it gets to the colon, it starts building and releasing this environment that actually we think fosters something that's favorable for the response of immunotherapy. And so this combination really led to a significant delay in tumor growth, more responses, but, you know, I can't articulate this enough, which is why I put it in large font here, but this is very, very early data. So I don't suggest that you necessarily act on this at this point. However, you know, our group is launching a couple of clinical trials that add CBM588 to other regimens. We're actually starting a study where we add it to cabozantinib and nivolumab. So, you know, if you're in the LA area, or if you know patients in the LA area, that's something we would encourage participation in. Okay, so I wanted to kind of also give you a couple of other, you know, what's on the horizon elements. And I think I've got about 10 minutes left if I've got my timing right here before we launch into some Q&A. But basically, you know, what's on the horizon, I think really builds on this paradigm of targeted therapy. And this is a very simplistic overview, but, you know, I think you guys know very well by now, my blue and my yellow and my purple and my pink. I'm adding here a red, which is this protein called HIF2, which plays a role in actually making this pizza slice that feeds into this whole pathway over here. So for the longest time, we knew that HIF2 was potentially a culprit in driving kidney cancer growth, but we didn't have a really great way to target it. It's kind of like the same dilemma that we had, you know, when Dr. Gore and I were in medical school. We knew these proteins were there. We just did not know what to do about them. And so what's been developed more recently is drugs that can actually hit this particular protein here. So there's a drug called belzutifan I know these drugs are available in clinical trials up and down the West Coast, and this is quite exciting, actually. Belzutifan is able to inhibit HIF. We've seen some really encouraging data early on with this. The data that we've seen to date is, generally speaking, in the context of patients that have received multiple prior lines of therapy. So if you walk into your oncologist clinic, by the way, this drug is not approved yet, but if you walk into your oncologist clinic, the data that exists so far is not for first-line therapy, but is for therapy in much more advanced disease. But your oncologist may, and we're not running this particular study, but your oncologist may have studies that are actually comparing belzutifan in combination against some of the existing standards. So much like, these studies all built on the backbone of sunitinib and compared against sunitinib, you're now having studies that actually explore belzutifan plus some of these regimens here, which I think is quite exciting. The other thing that's on the horizon, which I'm quite excited about, is the premise of exploiting something that sits on the surface of kidney cancer cells. There's many particular proteins that sit on the surface of kidney cancer cells. I have to tell you that functionally, we don't know quite what they do, but they may potentially be something that we can use and exploit as a target for new therapies. There's one approach that you may have heard of in other diseases, called CAR T-cell therapy. So CAR T-cells have made a huge splash in lymphoma and other diseases. And what's unique about lymphoma is a lot of lymphoma cells they're kind of a one-trick pony. They express one particular protein that we can send these CAR T-cells after. These are the same T-cells that I showed you in previous slides, but they're engineered to really get the mindset to go after a specific protein. So in lymphoma, easy, right? What's been really challenging is taking this premise and extending it to solid tumors like kidney cancer and lung cancer, et cetera. So I would tell you that CAR T cells are much more at an infancy. I think at many institutions, including ours, we're running trials that explore 2 CAR T cells in specifically. One is called Allo316. The other is called CTX130. This is a really, kind of a simplified schematic here, but you can think of these cells as having these homing missiles that direct them right towards CD70 on the tumor cell. And, basically, you can think of the CD70 as being kind of a kill switch. I think that this is an interesting premise that you're probably going to hear more and more about. I'm really keeping my fingers and toes crossed that this is a successful approach, for patients down the line, because at least what we see in the context of lymphoma is that this might be a quote unquote one and done approach. We saw this with IL-2 years ago where, amongst the, small subset of individuals who respond, you can have a really long and durable response to treatment. The hope is that with CAR T cells, you might evolve with the same, but that's a big question mark right now. I think I would be remiss not to discuss this study of what's on the horizon. I didn't want to get too much into the weeds on this. I know many of our patients in attendance may not have metastatic disease, which is what I focus on and Dr. Tykodi focuses on day to day in the clinic. What you may have is localized disease that's confined to the kidney that Dr. Gore or other surgeons have removed. So this was a really important trial that was just presented about month and a half ago at ASCO, which is our big annual meeting. This is the American Society of Clinical Oncology. This is, for instance, where we presented that microbiome data. This trial was a big one, included, the 1,000 patients, and basically it randomized them after they'd had surgery for localized kidney cancer to receive immune therapy with this drug pembrolizumab. And if I, backtrack to my slides on immune-based therapy, I just want you to recall that pembrolizumab, again, blocks this particular protein and reinvigorates the T cell. And this compared pembrolizumab to a placebo. And you may say to yourself, well, why a placebo in this case? I think I agree with that decision. There really was no great standard of care that we could use in this particular setting. So this study so far has shown that if you give pembrolizumab relative to placebo, you can actually delay the recurrence of kidney cancer. I think what many of us are waiting for is to see whether or not there's an improvement in overall survival. Again, this is data that's very contentious. I don't feel like we necessarily need to see that before we start administering this therapy in clinic, but certainly we need to wait for the FDA approval on this. And I and others have run a number of studies that, sort of fall into the same sort of category, if you will. Let's see here. So that's one study that I'm quite excited about. I'm happy to entertain questions during the discussion on this. I'm going to sort of rehash this slide that I showed you at the outset, which delineates the various types of kidney cancer. And, as I'd mentioned before, most of my talk today is really geared towards this clear cell subtype, which is in yellow. The treatments that I've shown you to date, all the data that I've reflected on really doesn't hinge on the green or the blue or the purple. And to be honest with you, that's a real shame. I wish that we had more studies that actually focus on these subtypes. But to that end, as I'd mentioned before, one of my real passions is papillary kidney cancer in the clinic. And I've been working for a long time, about a decade now, on the study that Dr. Gore referred to, which was published in The Lancet earlier this year, that looks at patients with papillary kidney cancer. Again, just to reiterate, I know I'm kind of jumping around. That last slide I showed you was localized disease. This is, again, going back to metastatic disease, so patients with stage 4 papillary kidney cancer. And this study, I think, was smart because it lends itself to the biology of papillary kidney cancer. We think that papillary kidney cancer is driven by a protein called MET, or MET, and that was one of the proteins that I showed you on one of our targeted therapy slides there, which I won't go back to in the interest of time. But we basically looked at sunitinib as a control, which we've done across many of the studies that I showed you in previous slides. You can see that sunitinib, again, was the comparator across most of the studies that I showed you previously. But what we did in the context of this particular trials, we compared sunitinib against 3 drugs that inhibit MET. And the bottom line is that cabozantinib was the winner here. It delayed tumor growth relative to sunitinib. So, this gives a clear answer. And for me, when I'm seeing patients with metastatic papillary kidney cancer, I really need to kind of have a definitive reason not to offer cabozantinib in the frontline setting based on the data that I just showed you. I think it's really probably the best level of evidence that we have for papillary kidney cancer. So I wanted to summarize here with a bunch of scribbles. Once again, my main takeaways from my discussion today. I think there's lots and lots of activity and a lot of reason to be hopeful as we think to frontline therapy for kidney cancer. I'd summarized here by saying I tend to use cabozantinib and nivolumab, or nivolumab and ipilimumab, for the reasons that I discussed. Again, that's targeted therapy with immune therapy or 2 immune therapies together. But I think that different oncologists, and there's so many experts in kidney cancer as you go from state to state, country to country, if your oncologist can give you good rationale for the drug regimen that they're using and why they're using it, I think that any of those regimens that I showed you is perfectly justifiable. But it has to be, and I would urge you again to challenge your oncologist and say, why are you supporting the regimen that you're supporting? Show me the evidence. And what I've walked you through is my logic here. I think that there's lots of really exciting drugs that are in the pipeline. I'm so glad that we had an attendee who asked about the role of the microbiome here, which I think is going to perhaps make a big splash, but it's not ready for prime time yet. We definitely need to get more data there. I think that the HIF2 inhibitors likewise are bound to make a big splash, and I'm hoping, fingers crossed, that CAR-T makes a big splash as well, but those trials are early and they're ongoing. Adjuvant treatment is on the horizon, and I think that I've shown you some of the excitement that I have around some of the trials that are happening in the rare subtypes of kidney cancer, like this study over here, and we certainly need more of those. I think that was my last slide, so I think we're right on time here, so I'm going to close there and try to tackle some Q&A. But Dr. Gore, Dr. Tykodi, and the entire SCCA team, thanks a lot for having me.
Thank you so much for that fantastic. Thank you so much for that fantastic talk, Monty. I really appreciate it. One question was about the role of genetic testing or personalized medicine. Do you have any comments about how that informs kidney cancer therapy?
Well, first of all, it sounds like your kids loved my talk. So I'm really, really quite excited. Either loved it or really hated it, one of the two, but it's great to hear them in the background. Super cute. So I want to just kind of go back to this slide over here. I did see that question pop up in the chat, and I think it's a brilliant one, a very important question too. what is the role of personalized medicine in oncology care? I'll tell you that, I may not, be the norm in this case. I do a lot of genomic profiling in my clinic. And I do it for most patients that walk through the door, in part because we have a mechanism of City of Hope that gets most of the genomic profiling funded. So that's quite helpful. And what does genomic profiling do? It actually refers to unraveling the DNA down here and determining the sequence of DNA in patients and using that and applying it to treatment. Where do I find it the most helpful? Well, I would tell you that it's probably most helpful in the context of identifying mutations in this pink protein over here. The data kind of goes back and forth on this, but if I see mutations in this gene that encodes for the protein mTOR, which is in light pink, it might potentially encourage me to use, let me see if I can go back here to my early slides. It might encourage me to use this drug everolimus a bit sooner. And so, our group, along with, the Harvard Cancer Center and many others, published this paper many years ago that seemed to suggest that if you have mutations here, you might have preferential benefit with everolimus. So it's a tool in my toolbox. But I'll tell you that the craziest things have come up when I've done gene profiling. We published on this. For instance, there's a mutation that hits about 4% of patients with lung cancer in a gene called ALK. And this particular protein is not at all common enough in kidney cancer for me to necessarily share this on this slide, right? It actually occurs in less than 1% of patients with kidney cancer. I think the actual estimate is 0.1%, in fact. But if you identify that patient, what our small series that we published has shown is that you can really have exquisite responses to treatments that are actually commonly applied in lung cancer. So, I'll give you the story. This is with permission of the patient. The barista at the coffee shop that I used to go to, 38 years old, was diagnosed with advanced kidney cancer. We were kind of unclear on what subtype she had. I did the genomic profiling and found one of these ALK inhibitors, ALK mutations. She'd failed most of the treatments that we saw in this diagram. She actually did well for over a year using ALK-directed therapy. So, they're kind of like a bit of a needle in a haystack. And again, many will say it doesn't justify the approach, but I tend to do a lot of gene sequencing in my clinic. So that I hope that answers that question around precision medicine.
Absolutely. Thank you so much. Dr. Tykodi actually wanted to know if you could share any anecdotes of using CAR T-cell therapy.
Yeah, it's so, early in the process that, unfortunately I'm kind of bound by confidentiality, but, maybe I can just sort of share with you some of the experiences that, my colleagues across other solid tumors have shared, and just really highlight some of the differences in the approach. So, the CAR Ts that I've referred to over here are kind of unique in that they're allogeneic CAR Ts. So there's two different types of CAR T cells. There's autologous CAR T cells, which is where we actually take, your blood, patient's blood, and actually modify that outside of the body and reinsert them and deliver them to the patient. These, on the other hand, are allogeneic CAR T cells, where we actually take these cells, from a donor, manipulate them in a very specific fashion. We actually use a technique called CRISPR, in order to do this, and then we deliver them to the patient. And there's pros and cons to both approaches, as you might imagine, right? One of the real benefits, I would say, and I'm totally oversimplifying the discussion here, but one of the real benefits with perhaps the allogeneic approach is that the autologous approach, where you're withdrawing, a patient's own cells, takes a lot of time. And oftentimes we don't have that sort of time in the kidney cancer clinic, right? We need to make a decision on therapy and we need to act fast. So allogeneic therapy holds that potential promise. I think it's interesting to just kind of take a step back and think about how these therapies are rendered. Because I mentioned from the outset that we barely ever use chemotherapy in treating kidney cancer, right? And I mentioned that we use it in these rare circumstances like collecting duct and medullary kidney cancer. But this is one of those scenarios where we're using CAR T cells that we actually do use chemotherapy. We use something called conditioning chemotherapy, which is where we actually give a very common regimen now. It's fairly standard across most CAR T cell protocols, where we actually try to just give you enough chemotherapy to deplete your body's immune cells to the point that these other cells can swoop in. These CAR T cells can swoop in and repopulate and reconstitute your body's immune system. So the way that many of these studies look is that you might actually consent for the clinical trial to get the CAR T cells, or, you know, if you have lymphoma or myeloma, some of the settings where these drugs are approved, you know, your physician will discuss it with you and you'll offer your consent to proceed with the therapy. Then you might get chemotherapy for about 3 to 4 days. And then you will get the CAR T cells. And then we'll monitor and watch and see what happens to your blood counts. We'll monitor your response to therapy. So it's a very different approach. You know, there are scenarios where you might consider redosing with these drugs. But what I would suggest is that overall, one of the real attractions of using CAR T cells is that if, you know, we're right, and if CD70 is something that is pervasively and consistently expressed in kidney cancer cells, if we get these CAR T cells in, and if we are able to get them to, you know, drive against these cells, this could be potentially a one and done approach. We just don't know that right now. We need the clinical trials to be done to sort that out. But, you know, I think that's kind of the holy grail, right? Is just, you know, maybe coming up with a one-time therapy. So you don't have to be on targeted therapy and immunotherapy for eons and eons. But I can't emphasize enough that it's still under investigation.
Thank you so much. You know, you did show some data on adjuvant. Obviously, I'm a urologist, and so I think about optimizing outcomes for patients with presumed localized disease. Are you thinking that you'll be using pembrolizumab in the adjuvant setting, or are you thinking about what patients you might disproportionately select for adjuvant pembrolizumab?
So just as my kids just got home from soccer, so you're probably going to hear them screaming in the background in just a minute. But you know, based on the data that you see there, I have to tell you, I'm in the yes camp for adjuvant immunotherapy in this setting. What I would love to see, just for confirmation, is, you know, I'd love to see the full publication. Right now, you know, Dr. Gore and Dr. Tykodi and I have seen the slides that were presented at a major meeting. But, you know, in 10, 12, 20 slides, you can't get the full picture of a clinical trial. You want to really dive deep and see the full published manuscript. And, you know, I think that's really fundamental for the three of us as we're deciding on therapy. So I'd want to see that. I'd want to see perhaps, you know, a bit more around the survival in this trial. But the really compelling thing, I think, would be if we start seeing a consistent result across other studies in the same space. So, you know, I've run a study with colleagues in urology and medical oncology, a trial that had a very similar format. So we looked at immunotherapy, this time with a drug called atezolizumab against placebo. So we're hoping that those results will come out soon. You know, there's other trials looking at combination immunotherapy versus placebo. There's slight permutations. And, you know, John, I think this kind of dates back to the data that we had for targeted therapy as an adjuvant approach or a post-operative approach. I think none of us were really truly satisfied with that data because we had one positive study across, you know, 7 or 8 others that were completely negative. So if I start seeing a really consistent signal across these studies, that's really going to be the key for me to say, this is solid. This is a good approach.
Yeah, I feel like just conceptually, you know, I've always thought that, you know, for example, stage 2 kidney cancer is this unique cancer where it's allowed to grow to a certain size, but without any discrete invasive behavior. So it's this disproportionately well-behaved large tumor, and, you know, probably, you know, benefits less from consideration of something like adjuvant immunotherapy, whereas obviously, you know, T3 tumors are much more concerning. I think this is a really interesting question. So making the analogy to agricultural pest control, do you have any thoughts, maybe specific to CAR T cells, about how the dosage can be used to manage, you know, recurrence versus more aggressive dosage to eliminate the disease entirely, and how you can modulate some of these therapies to be more or less aggressive or have a different intent for their use?
Monty, you're
Oh,
on
I
mute.
mute myself. Sorry, guys. I knew I was going to do that at least once here. But, I think with the targeted therapies, we know that there's a dose response. And what I mean by that is that, if you increase the dose, you're probably going to see a greater degree of tumor shrinkage. That phenomenon has been vetted pretty early on in the development of targeted therapies. We saw that, for instance, with sunitinib, that first drug that, I'd suggested has been approved. We use a dose of sunitinib of 50 milligrams, but there's an investigator in Canada, Jorg Bjarnson, at Sunnybrook, which is in Ontario. He's really made a name for himself by, looking at doses of 75 or 100 of sunitinib, right? And, he's shown nicely that if you go up on dose, you're going to get a better response. I think the more important question to ask is around tolerability. I should point out that with the immune-based therapies, there's really no benefit in sort of escalating dose or decreasing dose, et cetera. These are fixed doses given on fixed intervals. But the big question that we should be asking ourselves is tolerability. So for instance, and I'm going to refer to my slides once again here. This is a big deal for me, and it's something I think a lot about because with this regimen of lenvatinib and pembrolizumab, in the trials that initially led to this regimen's approval, Dr. Tykodi and I were using doses of 18 milligrams in the second and third line setting, meaning that we actually used to use this drug for several years before this trial at a lower dose of 18 milligrams. And I already found that dose to be very challenging. We know that if you go up on the doses they did in this study to 20 milligrams, you might get actually more bang in terms of generating a response. The question is, are you going to get more in terms of diarrhea? Are you going to get more in terms of hand-foot syndrome, et cetera? Is the tolerability of this regimen going to be challenged? Because, my goal when we're starting these regimens is not just to, get that great response, but to get the great response and have it be sustained. So that's very different from the approach taken with cabozantinib, where, and this is a very subtle point. So, but I think it's an important one, where again, Dr. Tykodi and I have been using a dose of cabozantinib at 60 milligrams for years for patients that have progressed on treatment, gone to second line and third line therapy. We actually brought that dose down in the frontline setting in the context of this trial to 40 milligrams. And initially, when the company had approached me about this decision, I thought to myself, I'm not sure this is a great idea. If you go down on the dose, you're not going to see the same level of benefit. But lo and behold, we see a benefit in quality of life. We see that, as I mentioned before, all those major marks, overall survival, delay in cancer growth, et cetera, were met. So, I think that this has really sort of taught me over the years that maxing out on dose shouldn't be the goal. Getting to that right dose that's sustainable is really key in this setting. That's a very long-winded response to your question, John.
But a terrific one. Thank you so much. We have a question about how you determine how long a course of therapy is. So the question is, what determines the length of a course of combination targeted and immunotherapy treatment? There probably is some nuanced context there also that we're not getting.
Right. So if I'm being a total purist, I would suggest that, and again, I'm going to highlight these 4 studies over here. With these 3 in the top right, bottom right, and bottom left, I would tell you that, by and large, it's probably necessary to continue the drugs in perpetuity, with one exception. In the study on the bottom left, they actually stopped the immune therapy with pembrolizumab at the 2-year mark. So that seems okay. At this point, I think that it's still early to interpret that data and a bit challenging. One of the real benefits of nivolumab and ipilimumab, and Dr. Tykodi and I have chatted about this before, and I'm sure he'd agree, is that there's the potential to, stop therapy in a number of patients and have really, kind of continued and persistent benefit with this regimen. So, in many patients on this regimen at the 1 or 2 year mark, if they're having a really deep and, near complete response, I'll have that conversation with them and say, hey, you're doing awesome. Do you want to stop? Now, there are patients who say, I don't want to, or I don't feel comfortable doing it. If they're having no toxicity associated with the regimen, I'll continue. I really try to put that decision, in the patient's hands, but we do have many detailed conversations around discontinuation of these drugs as we hit, those milestones of a year or 2 of therapy. Dr. Tykodi, I'd be interested in your impression of that as well.
Yeah, Monty, I agree. A lot of the trials are formatted to stop the immunotherapy drugs at 2 years. And we have that conversation in the clinic with patients that have sustained disease control without a complete response. And exactly as you said, I make it an option for patients and present the rationale, but it's not mandatory. And so some patients want to keep going. Some patients are happy to stop. And in our hands, a cohort of patients that have stopped on purpose at 2 years have done extremely well. Nobody's had rapid disease progression. A couple of patients with 1.5 to 2 years of follow-up are starting to see some increase in tumor, but very slow. And we certainly have the option to restart their therapy, which we're talking about. We're convinced it's a sensible choice to make. Time will tell if some people have, essentially permanent disease control, or if everybody eventually starts to grow again. We just don't know. Our lead patients are only a couple of years off of therapy.
Absolutely.
Monty, we only have a couple minutes left. We obviously have some trials that are brewing, but in your routine clinical practice, how are you integrating cytoreductive nephrectomy into the patients that you're seeing that maybe aren't going on a clinical trial?
Yeah, no, absolutely. It's a great question. I think that this is kind of the classic medical school teaching, and I don't think it's really changed a whole lot, Dr. Gore, since you and I were, training together so many years ago. But if you're really having a lot of pain related to, Dr. Gore, by the way, is referring to the concept of having surgery to remove the kidney in kidney cancer once you already have this disease that's migrated to other sites, the lung, the bone, et cetera, right? So let's imagine for a second a patient who comes to my clinic, and I see this every week, a patient who has that tumor that's located within the kidney, spread of their cancers to the lungs and bones. How do I decide whether or not that patient needs surgery right away? If they're having a lot of pain related to the kidney tumor, usually that pain is going to be in the flank on the same side as their kidney tumor is located. If they're having blood that's emanating in the urine, and a significant amount of blood, or if they have, and this is a tough one, but paraneoplastic syndromes. This is something that comes up not so rarely in the kidney cancer clinic. And these are things that are actually driven by chemicals that the kidney cancer is releasing. So this might manifest as an increase in calcium levels, other lab-based issues. Those are the settings where I'm thinking to myself, okay, I need to get this patient to Dr. Gore to have their kidney removed. So in those particular settings, that really takes precedence. And I would probably side with this regimen of nivolumab and ipilimumab in that setting, because it really sort of offers this potential benefit of not having a targeted therapy. So I wrote in my scribble here, good if considering surgery, may spare long-term toxicity of targeted therapy. But the issue with targeted therapy in the context of surgery is that, when I send that patient to Dr. Gore and when he operates, I really don't feel comfortable starting targeted therapy for another 4 to 6 weeks thereafter until they've had good, appropriate wound healing. And that may be a setback for the patient. So that's why in the context of surgery, I tend to favor this regimen. Now, if the patient is not incurring those symptoms, let's say that they're not having bleeding, they're having no pain, calcium levels, et cetera, are looking just fine, right? Then I would say, okay, I've got a little bit more time here. This patient that I described has disease in the bones, they've got disease in the lungs, pretty bulky disease. I know that this elicits a higher response rate. So let's start with this regimen, right? And let's reconvene at a later time to discuss whether or not surgery is relevant. That tends to be my most common mode of practice nowadays. What I'm finding really interesting, Dr. Gore, is that, what I'll usually do is I'll present these cases at our tumor board where, I'm sitting down with my urologist at City of Hope and my radiologists. And very oftentimes, I'll be struck with this dilemma of whether or not to operate. But, as we start on these targeted regimens, these response rates are so high, the tumor in the kidney just keeps shrinking and shrinking, and it obviates the need for surgery altogether down the line. So, I've been struck by how often that's been happening. Having said that, I think the best thing to do, I'm going to use the very cliche answer and say, let's try for a clinical trial. We just opened up a study called PROBE, which is a study that's taking individuals in that specific setting that I described, starting on targeted therapy or immune therapy. They have a kidney tumor that's in place and they get randomized to do surgery or not. And from a patient's perspective, putting myself in your shoes, I see how anxiety provoking that could be to leave a decision like surgery up to randomization. But, you know, if I can tell you from my heart of hearts, you know, it really is a decision that, you know, I think there's not a lot of great evidence for or against. So to undergo that randomization, I think is reasonable and ethical. And, you know, I certainly think the patients that go on these clinical trials are heroes, but I understand the dilemma that they're facing in that situation.
I think our practice is very similar, where we have a much higher threshold for early cytoreduction than we used to. You know, we always tell patients systemic disease needs systemic treatment. One final question, and then I know you need to go. Do you ever biopsy a presumed metastatic site that seemingly has done well on therapy, just to see if you can prove if there's still viable tumor in it?
You know, it's a great question. I ran into this dilemma with a longtime patient of mine. I actually just presented his case at Tumor Board. You know, and the challenge that I have in this situation, he's been on therapy, you know, for years, but had fairly aggressive disease from the get-go, is if I get that biopsy done, what is the chance that I'm running into a false negative in this circumstance, right? So, you know, meaning I do the biopsy, I get maybe the wrong spot or something, right? And I pull back that tissue, I see nothing under the microscope. And then I've really potentially shortchanged that patient. So, you know, I don't tend to do that much in my clinical practice. You know, it tends to be a very involved conversation with the patient. If they're really experiencing difficulties in terms of toxicity, et cetera, perhaps there's more rationale to do that. But if the patient's doing really well, I sometimes will forego that biopsy, but it's a great question.
Well, I can't thank you enough for joining us this morning. That was a really fantastic talk, very unique. And I appreciate your perspective and your expertise. And I'm glad it was worth the 4-year wait.
Thanks a lot, guys. Talk to you later. Bye-bye.
Our next speaker is Lauren Facchini. So Lauren provides genetic counseling for a number of hereditary cancer syndromes. She's been working with us in our kidney cancer multidisciplinary clinic for several years. She has a special interest and expertise in GU malignancies and tries to help patients understand how these genetic test results can influence their risk and their family's risk for cancer now and down the road. So we're delighted to have Lauren today to talk with us about genetic testing for patients with kidney cancers.
Great, thank you guys. I'm going to try and share my screen here. Okay. Alrighty. Perfect. So I think you guys can see what I'm seeing at this point, and hopefully hear me. Again, my name is Lauren. I'm a genetic counselor here at Seattle Cancer Care Alliance. We're going to be talking a little bit about genetic testing for patients with kidney cancers. We also have Dr. Marianne Dubart-Galt on the line. She's our clinical geneticist here at Seattle Cancer Care Alliance. And we weren't sure if she was going to be able to join us or not, but we're very happy she's here. So I'll go through the presentation, but she may jump in at various points and help answer questions along the way as well. Okay. So for today, we're going to start off by just kind of reviewing Cancer Genetics 101 with you guys. We're also going to specifically talk about hereditary kidney cancer. And for the purposes of today, I am going to really focus on renal cell carcinoma, just given that it's the most common type. Certainly, there are other types of kidney cancers that may have genetic factors associated with those risks, but we're not really going to focus on those for today. We're then going to talk a little bit just about genetic testing in general, the pros and cons of doing that testing. We're going to go through an example case, and then we're just going to end on a note on direct-to-consumer genetic testing, since I tend to get a lot of questions about that when I do these talks. So thinking about 23andMe, Ancestry.com, those types of things. Okay. So let's start off with a brief overview of Genetics 101. I'm going to take you back to your high school biology course. Essentially, when we zoom in our cells, we have chromosomes. We have 23 sets of chromosomes, half from mom, half from dad. And essentially, our DNA is wound up nice and tight on those chromosomes. And if we kind of unwind that DNA, we see that there are pieces of the DNA called genes right here. And those genes essentially have a specific job. So they encode for a protein, and then that protein has a job within the body. And we've talked a lot about proteins on the last talk, but I really just kind of wanted to clarify and define what these things are for you guys. But when we're talking about genes, we're talking about pieces of the DNA that encode for specific proteins. What are we talking about when we mean genetic mutations? So genetic mutations are changes within the DNA. So parts of these genes where there's actual changes that might look like a specific letter change, kind of highlighted here. We see that there was a T. And then when we look at a person's DNA, we see that we actually see a C instead of a T. So it's like a spelling change. Sometimes there's also missing or added parts to these genes. So inserted letters where they shouldn't be, or missing sections where there shouldn't be. But in general, we call these things genetic mutations. We all have genetic changes that are actually benign, normal, harmless. They essentially make me, me, and you guys, you. But sometimes there is a genetic change in a gene whose role it is to protect you against cancer. And when that genetic change essentially prevents the gene from being read properly, it stops that protein from being made, or maybe it's making too much protein. And in general, we see that because of these errors in the protein quality, you might be more prone to get cancer. I also want to just kind of use this example of a saying I learned in grad school. The saying is, all cancer is genetic, but not all cancer is inherited. And essentially what the first half of the saying is referring to is the fact that cancer is caused by genetic mutations that control the way our cells function. Right. So instead of a typical cell where we might have a genetic change and that's caught by the cell, and then the cell essentially has apoptosis or suicide, meaning it just kind of stops right there. What we see in cancer is that it's not caught. These genetic mutations actually build up one on top of each other. We see lots of them within the cancer cells. And so cancer itself has its own kind of set of these genetic mutations. And then the second half of the saying is referring to the fact that these genetic mutations, as I've kind of alluded to, they fall into two categories. The first is somatic mutations. So again, every tumor has its own set of genetic mutations. These are things that are acquired, meaning they happen just to the cancer itself. And that can be due to environmental risk factors, age-related factors, a whole bunch of different things impact those developments, essentially. And then there's also germline mutations, and a germline mutation is inherited. So that means this wasn't something that just developed in the tumor. It was actually something that the individual was born with. So they were born with this genetic mutation present in every single cell of their body. And these are what we consider to be hereditary types of cancer. So cancers where we know that it's due to this underlying genetic mutation that the person was born with, and it was essentially putting them at this increased risk for cancer, essentially since they were born. And for the focus of today, we're really going to be focusing on these germline genetic testing. So there's different types of genetic testing, as I think we've kind of alluded to. There's genetic testing that helps us look at the tumor mutations. Those can help determine the nature of cancer and kind of help guide treatments. We don't see that a ton in kidney cancer, although a lot of groups are starting to do it, as we mentioned previously. But we do see it in a lot of like breast cancers and prostate cancers, things like that, where that testing is very integral. But for today, we're really going to be focused on germline genetic testing. So looking at those inherited risks. Okay. So let's just talk a little bit about hereditary renal cell carcinoma. What I tell all my patients is, most cases of renal cell carcinoma are sporadic, meaning they essentially happen by chance. That chance can be influenced by age, it can be influenced by environmental risk factors, lifestyle risk factors, a whole bunch of different things kind of contribute to those risks. And sometimes they just kind of happen on their own. There really isn't a rhyme or reason for it. But what we know is that for about 5 to 10% of all cancer cases, and we think this is pretty specific to renal cell carcinoma, the person with the cancer actually has an underlying hereditary or genetic mutation. So we think that overall about 5 to 10% of renal cell carcinoma is hereditary. The example I like to use is, if we were to test every single patient with kidney cancer at Seattle Cancer Care Alliance, we would expect that 5 to 10% of them would have a genetic mutation. And I will say we've seen this number in the research be quoted a little bit less than this. I've seen as low as 2 or 3%. I've also seen it quoted higher than this. I think this is kind of a good middle ground and kind of representative of cancer overall in terms of the percentage. Okay, so, when we're taking a family history in clinic, when I'm looking at someone's own cancer and I'm kind of meeting with them, the things I do when I'm taking a family history and I'm meeting with that person is I'm essentially looking for features of hereditary renal cell carcinoma. I'm trying to say, what's the chance that this person falls into that 5 to 10% group of people who have these underlying genetic or germline mutations? And so things I look at are first and foremost age of onset. I get more concerned about a hereditary renal cell carcinoma when I see that someone's been diagnosed under the age of 50. I will say there are exceptions to this. Things like translocation RCC, we know affect people at younger ages, but typically that isn't due to a germline genetic mutation. So again, there are exceptions to these rules, but in general, these are the things I think of. Another thing I look at is someone's had bilateral or multifocal tumors. So, having kidney cancer on one side, especially at an older age, isn't incredibly uncommon or suspicious of a hereditary component. But when we see that it's on both kidneys and perhaps at a young age, that is much more concerning. And kind of as a rule for thumb, I end up testing most of my patients, or at least talking about testing with most of my patients who have bilateral renal cell carcinoma. It is just one of those risk factors where we say, you know what, let's go ahead and meet with that person and discuss genetic testing. Other things I look at is the family history. So certainly having a family history of renal cell carcinoma will increase our suspicion of our hereditary renal cell carcinoma syndrome in the family. Again, these germline mutations are typically inherited. Sometimes they are a new mutation in a person, but I would say at most, there's a couple conditions where that happens maybe 20% of the time. Most of the time, these things are inherited. They did come from a mother or a father. So typically on one side of the family or another, we see other people affected with RCC. We can also see related types of cancers as well. Things like neuroendocrine tumors, which we know can run with certain hereditary conditions. If we see those in a family, we might also be suspicious. So it's not just kidney cancer we're looking at all the different types of cancers. And typically when we think about like close relatives and we're not thinking about like your fourth cousin in Germany who also had kidney cancer. We're thinking about your first, second, and third degree relatives. So siblings, children, parents, aunts, uncles, cousins. I will potentially think about grandparents and great-grandparents even, but we don't go much further than that. And then we also look at the pathology or the histology. This can be very, very important for hereditary renal cell carcinoma. We know that with a lot of these hereditary syndromes, they have a prevalence for certain histologies. And so when I see more rare things like papillary renal cell carcinoma, that's actually kind of a red flag. And I tend to meet with pretty much everyone, even if you're over 850. Maybe not if you're in your 90s, but maybe if you're like in your 50s or 60s, certainly, and you have like papillary carcinoma or chromophobe RCC, that's something where we would want to meet with you and just kind of take a closer look at your family history and discuss genetic testing. Because we found that in those more rare histologies other than clear cell, we do see a higher incidence of it. And then other clinical features we look for. So these can be things like skin-related findings, lung findings, even uterine fibroids we look at, just because, again, these can be associated with specific hereditary renal cell carcinoma syndromes. And so whenever I meet with patients, I tend to ask about those three things: skin, lung, and uterine fibroids. And then if we have a suspicion for anything in particular, we might dive a little bit deeper and ask some more specific questions. Okay. So I just wanted to provide you guys with a brief list of some of the major hereditary renal cell carcinoma syndromes. One of the most well-known is von Hippel-Lindau disease or von Hippel-Lindau syndrome. I've seen it used interchangeably, which is caused by a germline mutation in the VHL gene. And what we've seen with this condition is that people have pretty early onset clear cell renal cell carcinoma. It can often be bilateral. We also see an increase just for neuroendocrine tumors and these tumors called hemangioblastomas. Other common things we see with hereditary RCC is a condition called hereditary leiomyomatosis renal cell carcinoma, which we abbreviate to HLRCC because that is a mouthful. But that is caused by mutations in the FH gene. We've seen that with that particular a condition that people have an increased risk for papillary type 2 renal cell carcinoma, but we also see FH-associated RCC and unspecified papillary RCC as well. And then this condition is the one that can lead to an increased risk for uterine fibroids, and then these skin leiomyomas, which are essentially these like raised little benign tumors on the skin. They can be kind of skin colored or slightly darker than that. And so again, something we look at. And then another condition is Birdhoff-Dubé syndrome. That's caused by mutations in the gene FLCN. And with that one, we tend to see chromophobe or oncocytic hybrid RCC. These folks also have an increased risk for lung cysts, which is a pretty unique finding. And with the lung cyst, we see that these people have a really high risk to actually have a lung collapse. And then also they can have skin papules. They look different than the ones for HLRCC. These tend to be little tumors on the skin follicles. So they're just like slightly raised bumps. We see those a lot on the face and the chest, the neck area. So I tend to look for those in my patients as well. And then down here on the last bullet row, I just listed a lot of the other genes related to hereditary RCC. So TSC1 and 2 causes tubular sclerosis syndrome. That's a classic condition. MET, which causes hereditary papillary renal cell carcinoma. So really thinking about papillary type 1, that's a pretty new one. BAP1, SDH, particularly B, but we also see the other ones, MIT-F, P10, and even a condition called Lynch syndrome, which we typically think about with kind of colon and GYN related cancers. We can see an increased risk for RCC with that too. So kind of an overall broad list there, and certainly there are more than just the ones I listed. Okay, so let's say, you've seen a genetic counselor, we've gone through the family history, and we do think that your family history and your own history is suspicious for an underlying renal cell carcinoma. One thing I always do is talk about the pros and cons of genetic testing with our patients. I would say the biggest benefits are, number one, kind of explain, why did this happen? For a lot of our patients, they are asking that question, why me or why my family? And for some of those families where we do identify the underlying genetic, cause, we can provide that explanation. And for a lot of our patients, we've seen that they've actually been very relieved by that. It's almost been like that answer where they're saying, now this makes sense. I completely understand it. Other things that can be, beneficial for is if we do identify a genetic mutation, it can inform someone's risks for additional tumors or cancers and other types of symptoms. As I kind of mentioned in those previous slides with some of those hereditary renal cell carcinoma conditions, there's multiple risk factors, there's multiple symptoms. And so certainly as a genetic counselor, my job is really to say, okay, if it's positive, what gene is this? What are the associated risks? And how are we going to follow you moving forward to make sure that either we prevent those things from happening or we are watching you closely so that if they happen, we catch them early. And then, I think another big reason why people end up doing genetic testing is for their family. And honestly, that tends to be the biggest reason why people end up going forward with genetic testing. They say, at this point in my life, I might not be so concerned for me, but I am concerned about my kids, or I'm concerned about my nieces and nephews and siblings. And if we can identify the genetic risk factor in the family, we can easily test other relatives for it. Siblings are going to have a 50-50 chance to have it. Children are going to have a 50-50 chance to have it. And if we can, just easily with a blood test or a saliva test say, do you have it or do you not? Well, then that can either be really reassuring for the family members who test negative and their future children. But for those who test positive, it again allows us to be proactive, following them appropriately. And if anything does happen in the future, we can treat it as best as possible. And then it can potentially help guide treatment. We talked a bit about this in the last talk, and I think this is very new for the world of kidney cancer. But we are starting to learn that with certain underlying genetic mutations, including germline genetic mutations, certain therapies work better than others. And so certainly we've seen this for TSC patients who have AMLs. There's a particular treatment approved for them. And then I have seen research both for VHL and HLRCC. And I think that research is only going to move forward in the future. So kind of aiming towards this kind of precision medicine approach. Okay. So let's talk a little bit about the drawbacks of genetic testing, or the reasons why people end up not moving forward with it. And what I tell all my patients is, like anything in medicine, this is optional to you. Genetic testing is nothing you have to do, even though it may be indicated. And these are some of the reasons why people end up declining it. Number one, for some folks, a negative result doesn't totally eliminate the risk. They say, well, you know what, even if this testing is negative, I'm still going to have to go through all these other things, or I still might be at a high risk for this or that. For a lot of my families who actually have a strong family history and that testing comes back negative, or we aren't able to identify the underlying genetic cause, I don't tell them they're perfectly in the clear just because they had a negative genetic test. Because of that family history, they're still going to have an increased risk, and we still might manage them as being high risk, even with a negative genetic test. So again, it's not always a perfect yes or no answer when it comes to genetic testing. Additionally, not more information isn't always helpful. A lot of our patients are going through a lot. They are trying to, sort out which treatments they need to do, which surgeries they need to do. And for them at this point in time, genetic testing might not be the right next step. They say, you know what, I might think about this in a year from now, but at this point, I can't take in more information. And I think it's going to cause more anxiety than it's going to be helpful. And so certainly we talk about timing, and if this is going to, at the end of the day, be helpful to the person, because we certainly want it to be. We don't want it to cause more anxiety than benefit. And then also, with genetic testing, we can get uncertain results. So patients are surprised to hear that not always is it a yes or no. Sometimes we do see a genetic change in one of these genes, but we're not sure if that genetic change is actually harming the gene and causing an increased risk for cancers or the associated syndrome. It very well could just be benign genetic information. Again, we all have these genetic changes, things that make me, and you guys, you. And so when we see these uncertain results, we kind of pause and we say, well, is this actually harming the gene or not? 90% of the time, they're not causing any sort of harm to the gene, so they're not impacting any sort of risk, but people still get concerned about them, understandably. And they say, you know what, if we pick up these uncertain variants, which we do in about 30% of our tests, I might not want to actually know that. And so I might, wait on testing for now. And then the other thing I wanted to talk about is genetic discrimination risks. And I actually have a next slide on this, because this tends to be a big concern for our patients. So with genetic discrimination, people are saying, okay, what's going to happen to these results? Are they going to be floating out in the open? Or my third cousin from France going to be able to contact me with them? And the short answer is no. So the type of testing we do is called clinical genetic testing. It's protected by HIPAA, but it's also protected by this law called GINA, the Genetic Information Non-Discrimination Act. This law was passed in 2008, and it's a federal law that says specifically health insurance companies and places of employment can't use this against you. So they can't change your rates. They can't deny you coverage. It doesn't become, say, a pre-existing condition, which is great. But there are limitations to these rules. So the first limitation is for federal health services. So we think of folks on VA or TRICARE or Indian Health Services. GINA doesn't always apply to them. And then also when we think about types of insurance like life, long-term care, and disability insurance, GINA doesn't specifically talk about those types of insurances. So, and we have seen that like life insurance can ask for your health records, and they're savvy enough to look at those genetic testing. So certainly when I have like young folks who are unaffected, maybe don't have life insurance yet, we certainly want to talk about this with them just to make sure they have those policies if they want them and they're not concerned about that genetic discrimination. Okay. Genetic counselors, I just provided a little slide here because my field's a little bit unique, and most patients I meet with haven't even heard of my career. But essentially, genetic counselors are trained both in medical genetics and counseling to help patients, their families, and other providers navigate the world of hereditary cancer syndromes. So again, what I do with I meet with a patient is I take a complete family history. We talk about all these things I've mentioned in the previous slides, and kind of we also work with insurance to see, okay, what's going to be covered, what's not, and does this make sense to do it for each patient. I wanted to provide some local genetic counseling resources in these slides as well for folks who are here in the Pacific Northwest. So Seattle Cancer Care Alliance has genetic counselors, not just at South Lake Union, but also at Evergreen Hospital, Northwest Hospital, Overlake Hospital, and now even on the peninsula. So certainly we're trying to go to the further out areas. University of Washington also has a great medical genetics clinic. Swedish, Kaiser, Virginia Mason, even Providence up in Everett, they all have genetic counselors. And I will say at Providence, they don't always only do breast cancer. They typically do a lot of different ones. And then there's also the Genetic Support Foundation, which is based out of Olympia. They're great. They do online and in-person genetic counseling, but they're kind of a separate entity that isn't associated with one hospital or another. And then if for anyone who's out of the Pacific Northwest area, there is, if you go to www.nsgc.org/find-a-genetic-counselor, you can actually type in your zip code and see a list of genetic counselors who are near to you. And then it helps you to be able to either self-refer or ask your doctor to referral to any of those folks. Okay, let's run through just a kind of an example case so you can kind of put all these things I've talked about together in your mind. So this is a made-up example, but it's taken from various patients I've seen. So this is a 51-year-old female patient. She was referred because she has a history of renal cell carcinoma at 46 and colon cancer at 49. So 2 primary cancers under the age of 50. That is pretty concerning for a hereditary risk factor on its own. Interestingly, when I was talking to her, I asked her if she had any skin findings, and she said, and it was on telemedicine, so it was a little bit hard to piece together, but she said, you know, it's crazy. My skin feels like sandpaper. I have all these bumps all over myself, and I've never known what they are. When we took her family history, we learned that her mother also had kidney cancer around about at age 60, so not particularly young. And then there was no further other types of cancer, but her grandfather did die young of unknown causes at 40. And then when I asked about lung findings, she said, you know, it's the weirdest thing. My niece actually had a pneumothorax. Her lung collapsed, and she probably wouldn't have mentioned that unless I brought it up. But certainly an interesting thing that she mentioned. And so we ended up doing her testing, and to no one's surprise, she was positive for FLCN, which is associated with Birdhog-Dubé syndrome. This leads to an increased risk for renal cell carcinoma, but also lung cysts and pneumothorax risks. The skin papules she was talking about are probably those little skin, essentially hair tumors called fibrofolliculomas. And so that's probably what's causing her sandpaper-like skin that she described. And then for next steps for her, we referred her to our local geneticist, Dr. Marianne Dubard-Galt, who's now following her long term. And then, you know, if there isn't a local geneticist in the area, because they are few and far between, certainly we can just refer to different specialties such as derm or a pulmonology to help manage these patients. And then, of course, testing for family members. So we want to think about getting kids tested, especially since they're all 18 or older, brother as well. And, you know, that niece is pretty suspicious. I have a feeling she has it. And if so, it had to come most likely from her brother, the patient's brother. It doesn't skip generations. So he most likely is an obligate carrier as well. Okay. Lastly, I just wanted to quickly end on a note on direct-to-consumer genetic testing because I get asked about this all the time. So direct-to-consumer tests are great for people who are interested in their ancestry, fun facts, do I like parsley or cilantro, etc. And if you just are looking at it for that reason, I say go for it. You know, they're certainly very fun. But these are not clinical grade genetic testing, and they should not be used for health information. I also want all my patients to be very leery of third-party sites that analyze raw data, such as Prometheus. So these things, you know, they say, well, we'll take all the raw data from 23andMe and we'll tell you what other genetic mutations are there. But we've done studies and over 40% of those results are actually false positives. So we've had lots of patients coming in thinking that they actually have these genetic syndromes when they don't. And so certainly if you happen to do any of these things like a third-party data analyzations, we want you to get those clinically confirmed with a clinical grade test through a genetic counselor. Okay, final takeaways, because I know I'm slightly over. But essentially for hereditary cancer syndromes, they are very rare. And I want to stress that most people here and in our audience will not have one of these things, but they can be helpful to know for you and your family, especially if you do have risk factors like we talked about earlier. Genetic counseling can help you determine if genetic testing is right for you and essentially what your result means and how to get family tested. And then if you're interested in genetic testing, clinical tests provide much more information direct-to-consumer test. So please reach out to one of your local genetic counselors, get a referral to them, or talk to your medical doctor. Okay. All right. Questions?
Lauren, that was really fantastic. That was almost a Q&A proof talk, but we do have a couple questions.
Okay.
One question from Dr. Tykodi is if you could comment on the concept of penetrance for pathogenic gene finding.
Yeah, so penetrance is essentially saying that, not everyone who has these genetic mutations is going to develop the associated conditions. So this is something I always stress with the patients, especially those who test positive and they're thinking about their kids. I think the automatic thing is to say, oh my goodness, my children are going to get these cancers. The short answer is no, they might not. They might never develop these types of cancers. It's really just saying you have an increased risk. And that's where the concept of penetrance comes in. It's not going to affect every person 100% of the time, like we classically see. I hope that answers your question.
Great answer. Frank Hidari has a question about papillary type 2 renal cell carcinoma. Is this always associated with the FH gene mutation?
Not from a hereditary perspective. Certainly, we've seen patients who have that type of cancer and they don't always have an underlying genetic mutation or germline genetic mutation, I should say, in the FH gene. So not always hereditary, no, but certainly at an increased risk, and I would encourage you to consider genetic testing.
And can I add that I think there are genes we don't understand yet, or other parts of the DNA that we have not studied enough to find other explanations, right? There's still a part of what Lauren described, part of the hereditary cancers that we can't explain at this time. And it's probably because we haven't done all the work to find all of these explanations yet. And that's coming, but for right now, we don't have the explanation.
Mm-hmm. Mm-hmm.
And then last question, and then we're ready for our break. Will research grade testing, so for example, RNA sequencing, give you more actionable information?
Oh, this person knows what they're talking about, potentially. So RNA testing has been kind of implemented by a few different labs. Ambry is the big one I think of, where they kind of do this paired germline testing with RNA analysis. And they're saying, well, maybe there's some underlying germline genetic mutation that our sequencing technology can't detect yet. So somewhere, something else that, is affecting actually the RNA. And so they look at the RNA to see if it's a complete product, because if it's not, then there should be some sort of underlying germline mutation in the gene that we may or may not be able to pick up. And so certainly we are seeing the advancement of RNA testing, a part of germline genetic testing. I wouldn't say that's really standard of care at this point, and it's definitely got a long way to go, but it is something we're considering, and we do use it in certain situations, especially for those variants of uncertain significance. That's where it can potentially be very important, and we can talk about that with patients. Marianne, do you have anything else to add? No.
I was going to add that it's part of the tools we use to make sense of something that we are not clear quite yet about, right? So there are more than one tool we can use, and RNA sequencing is one of the very upcoming tools that will be used a lot more going forward to really say if the DNA change has an implication on what the function of this DNA, part of DNA is supposed to be doing. Yeah.
Mm-hmm. Okay.
Well, thank you both. That was a terrific morning. I appreciate everyone's attention. We're going to take a short 10-minute break, and we'll be back at 11:15.
Hi, everyone. I have 11:15, so I'm going to kick off the rest of our program to keep us on schedule. I want to introduce our next speaker, Dr. Chris Miller is a research scientist on the Fred Hutch campus. And going back to the KidneyCAN talk this morning, Chris has funding from the Department of Defense, a targeted funding mechanism for kidney cancer, collaborates with colleagues here on our campus. And I've worked with Chris on research projects, and his talk today is Kidney Cancer on a Chip, 3D Microphysiological Modeling of Novel Cancer Therapies. So Chris, take it away.
Yeah, thank you very much, Dr. Tykodi, for inviting me to talk today. I'm really excited to tell you about my work with the CHIP project. Let me just share my screen. Okay, so that should be sharing. Great. So yes, I'm a staff scientist here at the Fred Hutch in the lab of Hootie Warren in the Clinical Research Division. And as Bryan Lewis told us earlier, it can take a very long time to get new drugs, especially oncology drugs, to the clinic. Among all these different types of diseases here, you can see that only 5% of drugs in oncology ever make it from a phase 1 clinical trial all the way to FDA approval. It can take a long time, up to 15 years, can cost billions of dollars. And one of the biggest problems is the average failure rate is 90%. 60% of drugs fail due to lack of efficacy, and 30% fail due to toxicity. So why is this? And part of it is that animal studies, usually in mice, don't translate well to humans. Sometimes drugs are found not to be toxic in mice that later show toxicity in humans. And in terms of cancer drug development, traditional, what we call two-dimensional cancer cell cultures and dishes, they really lack the architectural and functional complexity of human tumors. And so recently it's been recognized that what we call three-dimensional or 3D cancer cell cultures are more predictive of responses in the body. And so here's just an illustration of what we mean by a three-dimensional culture. So if we culture cancer cells, not in a flat plastic dish, but in balls of cells that more morphologically resemble tumors, and then embed these into a gel that's composed of collagen, the most abundant protein in the body, to create an extracellular matrix. And this is what would normally be surrounding tumors in the body, this collagen extracellular matrix. And so the advantages of this type of 3D culture is that the exposure of these tumor spheroids to medium and drugs is much more challenging to reach the core. And the cells that are in these 3D structures, unlike on a flat dish where they're all kind of in the same stage of the cell cycle, these 3D balls contain mixtures of proliferating, quiescent or sleeping, hypoxic or low oxygen, and necrotic or dying cells. And so that milieu of different cell types creates different patterns of response to drugs that more faithfully recapitulates what that would be for tumors in the body. And overall, it's been shown that what genes are turned off and turned on and what proteins are present turns out to be much more similar to tumors in the body when they're grown in these three-dimensional cultures. And generally, these spheroids are more resistant to treatments compared to cells grown in a flat dish, which reflects the resistance that is observed in the body. So combining the 3D concept of growing tumor spheroids as in 3D structures, recently there's been an effort to revolutionize the drug discovery process by creating fully human systems that we call human microphysiological systems, or organs and tissues on chips. And so they're called chips because the advances in the microfabrication techniques are similar to the silicon-based photolithography techniques used to create the silicon chips in computers. And these devices tend to be very small. They tend to be based on microfluidic channels, or small channels in which media can flow. And so far to date, there's been microphysiological systems that recapitulate many different organs, systems, and diseases in the body, as shown by the various examples for the different organ systems here, such as kidney, lung, liver, blood, vascularized tumor, skin, and etc. And so the goal of these systems is to be able to better recapitulate the three-dimensional architecture and function of human tissues outside of studying them in the actual human, to serve as a complement to animal models to improve the rate of success of drug development. So we here at the University of Washington a few years ago developed what we call a human renal cell carcinoma on a chip. And to do this, we use an off-the-shelf device from a company that's local here, spun out of the University of Washington, called Nordis. And this chip system here, it's about the size of a credit card, contains a region here shown highlighted in red, where we can infuse patient-derived spheroids, so from renal cell carcinoma that's obtained after a nephrectomy. And so these tumor spheroids are embedded in the collagen region, or we can use the patient-matched normal kidney cells for comparison. And so, and then through that, so then after this collagen region polymerizes or hardens with the tumor cells in place, we can then pull out a retaining rod and put in blood vessel cells to create an endothelial, or what we call a blood vessel structure. And then we can flow media through these devices that would be similar to kind of the flow through a blood vessel in the body. And when we do this, we can see here in the lower left, these vessels form nice tight cell-cell junctions, and they form nice blood vessel-like structures. But they don't sprout. These blood vessels don't do what we call sprouting. Now, if you go all the way over here to the far right, if we surround those vessels with tumor spheroids, you can see the clusters of the tumor aggregates here surrounding the vessel. That induces a robust sprouting of those blood vessels. And that's something that's a hallmark of renal cell carcinoma in the body. Whereas if we have the patient-matched normal adjacent kidney cells, the tissue harvested from the non-cancerous part of the kidney, that doesn't cause the very robust sprouting observation that we see. And here's just a movie of one of these vessels that we created by surrounding the blood vessel with tumor cells. You can see the very dramatic sprouting-like structures that come out of that blood vessel. And we can then use this system to study anti-angiogenesis agents. And so here's just an example on the left where you can see the vessel surrounded by a tumor spheroid, and you can see the sprouting that's induced from that vessel. But if we block, and this was mentioned earlier, one of the important targets on the surface of renal cell carcinoma cells, if we block one of the targets on the blood vessels that is stimulated by a protein secreted by the renal cell carcinoma spheroids that induces the sprouting, this VEGF-R2 blocker, we can block the sprouting phenotypes. This is just demonstrating that this is a suitable system using fully human tissues to study agents that block one of the important hallmarks of renal cell carcinoma. And so we've also adapted another system, a commercially available system from a company called AIM Biotech. And so their chip system is shown here on the top, and each of their 3 sites, microfluidic sites, looks like this. And then this is kind of blown up here down the bottom to kind of more cleanly see. There's a central region here where we have the tumor spheroids, and we've adapted this to put in the renal cell carcinoma spheroids. And this is embedded in that the collagen extracellular matrix here. And then adjacent, there are media flow channels where we can provide media with either test drugs, or in the case I'll show you, T cells later. And so the rest of the data I'll show you today is actually using this microphysiological system. And so I'm going to give you 2 examples of the research that we're doing with this renal cell carcinoma chip approach. First, I'll show you how we're using it to test novel, very early stage novel targeted therapeutics. And then also how we're using it to test tumor antigen-specific T-cell immunotherapies. And one of the advantages I'll just point out of this system before I get into the data is, it really allows us to study all types of renal cell carcinoma, not just clear cell, but the other less frequent types in the system. So it's amenable to, and because it uses primary patient tissues. Now, so the first example I'll talk to you about today is the example of developing a new targeted therapy in this chip system. And so here I'm going to show you how we were evaluating what we call death receptor 5 antibody nanocages in the renal cell carcinoma on a chip. So let me just take a minute to explain what is a death receptor 5 antibody nanocage. So many of you will know that antibodies are very useful reagents in research and in medicine. Antibodies are what can block things that we want to block. So shown here is, it would be a depiction of a tumor cell. And on the tumor cell is shown this receptor. It's a cell surface protein called death receptor 5. And this is very highly expressed on tumor cells, but not normal cells. In fact, in renal cell carcinoma, it's also very particularly highly expressed protein. And if this protein gets activated either by its natural trigger or by these antibodies that we can develop that can interact with it, it actually induces the cell to die. And that's why it's called a death receptor. And so this has been a very attractive target for cancer development, spanning back almost 20 years. But the clinical trials using just these free single antibodies were shown to be disappointing. It was shown that they really couldn't get enough of them to get to the tumors to really induce the kind of cell death signal that you'd want to see to kill the tumor cells. But recently here at the Institute for Protein Design at the University of Washington, there was an effort to develop these really higher order spherical structures that we call nano cages. They're called nano because of their size is in the order of nano sized. And so these clusters these are computationally designed proteins that incorporate, as you can see, many different antibodies into one structure. And that allows you to kind of get a lot of antibodies in one place at one time. So if an antibody is floating through the bloodstream and it happens to hook up with a receptor on the tumor cells, it's only one antibody. But in this case, if it happens to hook up and see its receptor, it brings along a lot of other antibodies. And you can see that really creates a really strong signal. And you can imagine a small lightning bolt coming from over here on the left, but over here, it's a gigantic lightning bolt signal telling the cell to die. And so we've tested this in our chip system. And this is just some highlights of the results. So on the left here, we make our spheroids, and those are labeled in green. And over 2 days in the chip system, you can see the cells in the spheroid, they start to invade. So invasion is the first step on the path to metastasis. And so these tumor cells, these are human renal cell carcinoma cells. They're very highly migratory. They invade into the collagen extracellular matrix, and you can see the strands that show that invasion. And over here on the right, if we add the antibody, death receptor 5 antibody nanocages, you can see there's a dramatic increase in the red staining in the cells. The red indicates a cell that is dead because it's unable to exclude the dye, which then goes and binds into the nucleus and the DNA in the cell. And so you can see the dramatic increase in the number of red staining, but you can also see that there's an essentially complete inhibition of the invasive phenotype of the spheroids. So we're very excited about the potency of these antibody nanocages. And just to highlight this invasive phenotype in a different image here, you can really see that happening when there's no drug present. And the amount of cell death is relatively low. It's confined to the middle region of the spheroids, you can see. But when you add the antibody nanocages, you can see down here in the lower left, the complete block of the infiltrative phenotype. And you can also see a dramatic increase in the staining of the dead cells, which is now not just confined to the middle region of the spheroids, but is all over the spheroid. And so one of the things that this system has allowed us to figure out and determine is so here's a comparison of the antibody when there's a whole bunch of them, in this case 12 antibodies per each nanocage, where we can deliver the very strong signal. This is very similar to what I just showed you. You can see in this additional experiment, we see a very dramatic increase in the number of dead cells, and you can see the invasive strands are gone. And when we do the same experiment with the free receptor antibodies, not clustered in the nanocages, you can see there is a slight increase in the number of dead cells, but this is unable to inhibit the invasive strands that come out of the spheroids. And in these systems, we can quantify this and to have statistics, and I won't really go into detail here other than to show you that this kind of an approach really reveals the marked cytotoxicity of the antibody nanocages, even at very low concentrations we tested compared to the free antibodies. So for the next part of my talk, I will show you how we're using the CHIP system to evaluate T-cell immunotherapy. We heard a lot about how CAR T-cell immunotherapy targeting CD70, for example, is really looking like a promising treatment that's in very early development. There's a lot of excitement about how T-cell immunotherapy has really revolutionized the treatment of lymphoma and other B-cell leukemias. And there's a really intense interest here at the Hutch and every cancer center to get this to work in solid tumors. And so T-cell immunotherapy, for those who aren't familiar, this is just a simple schematic that basically it's a procedure where T cells are collected from the patient. The patient who has cancer will donate their own blood, and the T cells are then removed from the blood. And then into those T cells, we genetically modify those T cells to have a receptor here shown on the surface that is specific to antigens or protein fragments that are found on the tumor cells. And then we can grow these in very large numbers in the laboratory into the millions and millions of cells, which are then infused back into the patients. And so the own patient's T cells, there's no issues of rejection of these cells in this depiction here. So the cells are reinfused back into the patient in large numbers. And now there's sufficient cells T cells to win the war, to target the tumor cells. And the T cells use these receptors that they're now equipped with to bind to the antigen targets on the tumor cells. And hopefully that leads to the killing of the tumor cells. So we're evaluating T-cell immunotherapy using the renal cell carcinoma on a chip approach. And here's just a schematic on the upper left that shows, again, the system we use where we have a central region in the chip device. And that's where we put the renal cell carcinoma spheroids, and they're embedded in the three-dimensional collagen matrix here. And then over here on the left, we can add T cells into this channel, and the T cells have a chance then to enter into the matrix and attack the renal cell carcinoma spheroids. And so the very basic questions we're asking as we're getting the system up and running is, first of all, and this shown here is just a depiction of blue T cells, and these blue triangles are just the structures of the device. And so these little gaps here are opportunities where the T cells can enter into the matrix. And so the question is, do the T cells invade the collagen extracellular matrix? In a traditional 2D cancer cell culture, when you just drop T cells into a liquid media, they of course will sink down to the bottom and contact the tumor cells. But in the body, they're going to have to penetrate through the collagen extracellular matrix. And so we can recapitulate that in our chip system and then test that. And so then the second question is, once they're in there, do they tend to accumulate around the tumor spheroids? Do they collect there in sufficient numbers to be able to do a response? And the response that we're looking for is the death of the spheroid. And so this is very early in its development, but we have some pretty promising early results. So this is some data showing you that, and so this is just a specific type of T cell. I won't go into the details, but this is a type of T cell that was equipped with a chimeric antigen receptor targeting a protein that's expressed on kidney cancer cells and other types of solid tumors, and in some cases, but not in all cases. So this is an example of after 22 hours, when we put the T cells here, you can see, I'm showing you just a blown up region of in the middle of the collagen matrix, that these T cells here labeled in blue, they really do robustly migrate into and infiltrate the collagen. And this took a lot of testing to really understand, different preparations of T cells don't all do this. And how do we handle the T cells in the laboratory and during the steps of introducing the gene modification to make them express the tumor antigen specific receptor? There's many different ways of handling the T cells. And so we have found a way that leads to a population of T cells that is very highly infiltrative. And that's the great first step. Next, we are able to show that these T cells, they do accumulate in regions where there are tumor cells. And here shown in green are the tumor cell targets. And after some time goes by in these chips, the T cells, they just aren't randomly found, like I showed you before. Now, when you have tumor cell targets here, they actually will hone in on the tumor targets. And so there's a dramatic increase in the association of the blue T cells with the green tumor cells. And we're investigating ways of measuring the cell death. Here's just one type of stain that we're using. We stain for an antibody, we stain for a protein that becomes present when cells are dying, and that's shown in the red staining here. So we're starting to get a signal that there may be some killing going on as well. Here's another example of a large spheroid that made it into the T cell interacting zone. And you can see the T cells, once they've entered the matrix, they aren't just randomly dispersed. They really do hone in on the tumor target, and there may be some killing going on. Again, just another example of this very robust infiltrative T cells that get into the matrix and associate with the spheroid. And this is only 22 hours, and we'll be looking at later time points for the killing activity as well. And then just one final slide. This is just 4 different pictures of an experiment, different regions of the chip, showing the blue T cells interacting with the tumor cells and leading to a very dramatic increase in the amount of red dead cells. And so we do have evidence of tumor cell association with the renal cell carcinoma spheroids and killing. And so here's just a summary of the kinds of questions that we can use this system to address. So, what are the best tumor antigen targets in renal cell carcinoma? What are the best T cell receptors and chimeric antigen receptors to arm the T cells with? Again, how does the handling of the T cells influence their ability to infiltrate the tumor microenvironment and kill the tumor cells? What are the properties of T cells that we see to be highly infiltrative and cytotoxic? And we can measure using RNA-seq, was mentioned earlier. It's a technique we can use to study those T cells to understand, what properties do they have, and those are the properties we would want them to have to be able to do what we want them to do. And then what really drives these T cells to associate with the tumor once they're found in the matrix? And this is an area of biology that's called chemokine signaling. And there's different chemokines and chemokine receptors that draw cells towards each other. And understanding those interactions, the specifics of them, would be very useful information. And we can also include blood vessels, as I showed you earlier, into the system and understand how now when there's blood vessels present, how does that influence the ability of T cells to transmigrate across those blood vessels? That's something they're going to have to do in the body. And we can also put other immune cells. It was asked earlier, why are the T cells sleeping in the first place? Well, one of the things we know is that the tumor microenvironment is a very immunosuppressive environment. Tumor cells are really good at telling T cells to die or to just sit there and rest. And they actually co-opt other types of immune cells. And one type of immune cell is actually a specific type of T cell called a T regulatory cell. And tumors are really good at activating regulatory T cells. So anyway, we can equip our chip system with one variable at a time to test these different interactions and how that influences T cell activity. And then also we can just test combinations of T cell therapies, either with immune checkpoint inhibitors or with, for example, the death receptor 5 nanocages I told you earlier. So I haven't been monitoring the questions, but I'll take a look at those to see if there are any, and I'd be happy to take live questions. But before I do, I just would like to acknowledge the individuals who work together to accomplish this research. First, Hootie Warren, who's an oncologist and investigator here at the Fred Hutch, a pioneer in T-cell immunotherapy. And members of his lab here that are highlighted and underlined form what we call our renal cell carcinoma team. And we have a biweekly meeting of this group, and it's a very active area of research in the Warren lab. And of course, Scott Tykodi really oversees most of the kidney cancer research in the Warren lab for us. And this, again, to separately thank Scott, he as one of the principal investigators who helped us land this DoD Kidney Cancer Research Program Award to be able to do these kinds of translational studies using the primary patient tumor samples. And we also work with Sri Ram Akhilesh, who's a renal pathologist at the University of Washington. And Julie Matthew, who is at the University of Washington, she really helped lead and connect us with the Institute for Protein Design to get the DR5 antibody nanocages into our chip system. And also like to thank Carla Yeager from Stan Riddell's lab, who has really helped us hone in on how to get T cells that infiltrate into our tumor chips. And of course, I have to thank our funding sources from the Cancer Consortium and the DoD, but really this work would not be possible without the philanthropic support of our very generous donors who have donated to the Fred Hutch for kidney cancer research. So with that, I would be happy to take any questions.
Fantastic. Thank you, Chris. I see one question in the Q&A window asking you if any work has been done on parameterizing models of cancer evolution using the chip technology.
I'm not exactly sure what is being asked there, but I can comment that we have some. We've thought about doing some types of experiments where, we know what the mutations are that lead to the development of renal carcinoma, but there's still really no good mouse models. Unlike many other cancers like breast cancer or prostate cancer, we have very well developed like mouse models of those cancers. It's been hard to develop that in mice, and we don't really understand why. If you introduce the mutations that we know are associated with renal cell carcinoma, why do those normal kidney cells then not go on to form? So in terms of cancer evolution, this system could be very useful to really say, okay, we have a normal kidney cell, and we know that doesn't induce the blood vessel sprouting. But if we introduce mutations either one at a time or sequentially, can we now edge that cell into a phenotype where it's more cancer-like and now where it can induce the sprouting of the blood vessels? So I'm not sure if that answers the question, but when I see cancer evolution, that's the kind of studies that we could be able to do in the CHIP system.
Chris, another question. How does the T cell move through the matrix in your system?
We're not really sure. I mean, I think T cells generally are just known to be, in the body. Their job is to go into and inspect tissues. So they have the cytoskeleton and type of ability to rearrange their shape in such a way to move to be able to do that. So it's not entirely unusual that T cells are found to infiltrate into collagen. That's what they want to do. But we have found that after handling them for some time in the lab, that they sort of can lose that ability. So, but yeah, I think just using the normal mechanisms of cell motility, actin skeleton rearrangement, and those kind of things.
Great. Another question. Any measurements on how much you've been able to decrease the 90% oncology drug failure rate using the CHIP approach?
Yeah, I think the CHIP approach really started out of the National Institutes of Health, what's called the NCATS, the National Center for Advancing Translational Science, partnered with the Food and Drug Administration and the DoD to develop the CHIP system. And this happened probably not quite 10 years ago yet, maybe 5 years ago. This really started, and the CHIP program has grown. I don't have a specific answer to that question. I can't yet point to drugs yet that have sort of gone through the process quicker. The field is continuing to grow more and more. The stage that it's at right now is there's a major effort to validate the model CHIP system. So people taking the CHIP systems who aren't the ones that developed them and just as outside observers trying to show their reproducibility. And so there's a major national effort to fund the evaluation of the reproducibility of the CHIP systems. So it's definitely a very early field. I think there's a lot of people who still as a funder, people who review funding, there's some skepticism. They're more used to the traditional mouse models. So it's hard to get an entire field to change, but more and more we are seeing pharmaceutical companies that are investing in this. And I know just from our own personal, research, it definitely reduces the number of animals that has to be used because you can get answers a lot quicker. Ultimately, the FDA still wants to see animal models, but we think this is going to help us get there quicker.
Yeah, in terms of the speed, Chris, for the audience, the mouse is the typical research reagent to try and design a quasi mimic of a human disease, growing a human tumor in a mouse model and then trying to treat it in some fashion. A short mouse experiment would typically be done in 28 days, 4 weeks for certain model systems, but often you have to wait longer to see what happens, as long as 90 days or 120 days. So a 3 or 4 month timeline for a single experiment to give you data. How fast can you do experiments with the CHIP system?
Yeah, so far for our angiogenesis readout, we can get that in 2 days. As soon as 2 days for the cell growth experiments with the drugs, again, 2 days. The T cell migration experiments, 2 days. So yeah, I mean, it's really rapid. You can get your answers really quickly. Do the cells infiltrate or not? You can get an answer very quickly. Do they kill the tumor cells or not? Again, to do that in mice, it's much faster. So dramatic acceleration of the pace.
Yeah. And any last comments? The T cells that you're showing the audience, are these just laboratory reagents to make a biological point, or are there actual T cells under development that could translate over to a bona fide human therapy?
Well, as you know, we're developing. We are in our lab developing an engineered T cell product that would use a patient's own T cells and engineer them to have a T cell receptor that binds to an antigen on renal cell carcinoma that is termed the 5T4 cancer tumor antigen. And so in all cases in our experiments, we do use human T cells that are harvested from, in this case, healthy donors to test equipping them with these receptors to see how they interact with tumor cells.
Excellent. I don't see any more questions for Dr. Miller. So thank you, Chris. That was fantastic. Let me introduce our next speaker for this afternoon, or the end of the morning session. Dr. Delphine Chen is a colleague of mine here. She's the Will B. Nelp Endowed Professor in Nuclear Medicine on our campus. She's the Director of Molecular Imaging at the SCCA campus, and is going to be talking to us this morning with the title, New Techniques for PET Imaging of Renal Cell Carcinoma.
Great, thanks, Scott, and thanks, John, both for the introduction and the invitation to speak. So I just arrived 2 years ago at the Seattle Cancer Care Alliance to build the molecular imaging program. So it's been great to work with Scott and John together on the kidney cancer initiative. So I'm going to review that with you today. So let me share my screen. And I will start this. Okay, so I hope you guys can see my slide. Okay, so I will start with just a broad overview of what molecular imaging and nuclear medicine is. We have a large role in cancer in general, but I think in kidney cancers, maybe a slightly lesser role just because we don't have the agents yet that are really helpful for guiding management decisions. Probably the most common scan you'll hear about is a renal scan. But basically what we do is we use radioactive labeled drugs that we either inject into a patient through an IV, we have them swallow it, or we have them inhale it. And it gives us functional or molecular information. So it's not just what a cancer looks like, but actually what is it doing? Is it actively growing? Is it using glucose? Is it, does it have a specific receptor expression? And I like to use a light bulb analogy in terms of how to distinguish, to illustrate what the information is that you get from nuclear medicine studies versus something like a CAT scan. So a CAT scan would be like a picture of a light bulb, but you haven't turned on the switch yet. When you turn on the switch and run the electricity through, then you know that it's actually lighting up or not. And that's kind of like the electricity is kind of like what we do when we inject these radioactive drugs into our patients to generate images. We actually also do therapy. So some of our agents are radioactive drugs that are actually for therapies. And so that's another growing area in nuclear medicine. And the imaging modalities you'll hear about are basically gamma cameras and SPECT-CT. As I said, renal scans are probably what we most commonly do for patients with renal cancer. And then PET, which is sometimes used for kidney cancer as well. So what is PET? So it stands for positron emission tomography. What that means is that our radioactive tracers, I'll just call them tracers for something simpler. So our radioactive tracers that we inject are labeled with a positron emitter. And so a positron is actually the exact opposite of an electron. And so positrons emitted collide, they annihilate, and generate these two annihilation photons. And these are what the detector in the PET-CT scanner detects. And I won't get into too much of the physics other than this is a great practical example of matter-antimatter interactions in medical use. But what this physics gives us is an actual inherently quantitative imaging technique. And so we can actually track exactly how much of the drug is actually being accumulated in a particular cancer. So as I mentioned, we use tracers. They're labeled with the positron emitter, and they can be attached all of these emit a positron that we can then use to image in PET. And then lutetium-177 is another isotope that delivers more of the energy to the cell itself where the drug goes. And so that's why it's useful for therapy. And I have this schematic here just showing you, this is pretty much a very generic schematic of most of the drugs, or of all the drugs that we use to either do PET imaging or to do therapy in nuclear medicine. So you have the drug, which can be almost anything. It could be a small molecule peptide antibody. It could be those nano cages that Dr. Miller was just talking about. You can add a linker and then add your radioactive isotope, and then you can inject that and then track wherever it goes. And so as I mentioned, one of the advantages is that it is quantitative. It also allows us to look at systems without perturbation. So that little red molecule represents the FDG. We're tracking physiologic or human biology without disturbing it. What that means for us is that when we develop new PET agents, there's a very high safety margin, meaning we almost never have allergic reactions to our radioactive drugs. And so because we give very small amounts of these tracers to be able to image them. And it's because of that radioactive label that we can image such a small amount of whatever drug it is we're imaging and get information about the cancer. So as I mentioned, we get quantitative images. That means you can assign a number to how much activity is being accumulated in a tumor. And then you can actually track how that number changes to assess how much of the drug we're injecting is actually accumulating. We also get very high resolution images because of the physics that I illustrated very briefly. So I have a picture here of FDG. This is the only chemical compound I will show to you guys. But FDG is our workhorse tracer for cancer imaging. It's labeled with F18, and this is an example of what an FDG PET image looks like. So the brain takes up a lot of glucose. It measures, as you can see, it's glucose, blood sugar. So it measures blood sugar or glucose uptake in cancer cells, and cancer cells tend to take up a very high level of glucose. So you can see normal brain, because your brain uses a lot of glucose. The heart muscle also uses glucose. And then you have, to a lesser extent, liver and spleen, and then the body gets rid of the extra FDG through the kidneys. And I will say this is one feature that makes it more difficult to use FDG for kidney cancer, and that's why one of the reasons why we don't use it as much is because it can be very hard to see the primary tumor when you have a lot of normal excretion. In this particular image, you can see there are all these black dots in the lower abdomen and in the pelvis. These are all lymph nodes that are cancer metastases. You can see that the FDG lights those up very easily. And you can also see that we can see very small nodes. So these are about 1 centimeter, and we can see sometimes lymph nodes that are 5 millimeters, and we can be more confident that they have metastatic involvement, which is very difficult to identify just on CT alone, because a lot of normal nodes will be in the size range of 1 centimeter or less. And so the added value of the PET is to actually show, is it taking up a lot of glucose, at least in the case of FDG, and to tell us whether those nodes actually have metastases or not. And in general, it's more sensitive for identifying metastases in other places like the bone, for example. As the bone gets destroyed, sometimes it can be very hard to see on CT, but then when you add the FDG, you can see it very easily. So as I said, PET imaging has been challenging for renal cell cancers, though, primarily because we don't have great tracers so far that image them really well. So as I mentioned, the FDG uptake, the normal excretion, makes it hard to see renal cell cancers. The other feature of renal cell cancers is that most of them don't actually take up a lot of FDG. Some of them are lower grade, less aggressive, and they don't tend to have a lot of FDG uptake. The more aggressive cancers, such as clear cell renal cell, that we've all been talking about a lot this morning, do tend to have higher uptake, and when you have metastases, you can also see them more easily on PET. But again, this is not always consistent. And so when you can see the metastases by CT or even by MRI, you may not need the FDG PET to find those metastases, and that's why PET has not been used as much for kidney cancers. So there are several new PET tracers that I'm going to talk about today that hold some promise in the area of kidney cancer. So first is, so these are targets that are that we are trying to image using PET. So one of them is carbonic anhydrase 9, another is CD8 T cells, and then last, I know this is a kidney cancer group, but the prostate specific membrane antigen, or PSMA, is actually a protein called that because it was originally identified in the prostate, but it turns out it is expressed in the endothelium in very highly vascular cancers, and kidney cancer is one of those highly vascular cancers. So I'll show you some images showing the potential utility for that. And then I will just touch very briefly on whether there are radiopharmaceutical therapies that might be useful as a new therapy modality for renal cell cancer. So as I mentioned, carbonic anhydrase 9 is an enzyme, a normal enzyme in the kidney, but expressed at a very low level. And it's consistently expressed at very high levels in clear cell renal cell. And so by imaging this particular enzyme, it may be useful in distinguishing malignant renal tumors from benign tumors, such as oncocytoma. Right now, we use MR and CT to try to make that distinction, but there's clearly some overlap in the features on CT or MRI for these tumors. And so sometimes the only way to know if it's a cancer or not is to either take it out or do a biopsy. And the other potential application is potentially for staging renal cell carcinoma. That's not really being developed so far, but as we identify tracers that can more sensitively and specifically detect metastases, that usually migrates into the space of, can we use that to determine the extent of disease better using the imaging tracer? So this is a preliminary paper that was published using girentuximab, which is an antibody that was originally developed as a therapy that targets the carbonic anhydrase 9. The therapy trials didn't work out as well as they had hoped, but they did, the antibody did bind to the renal cell cancer cells really well. So what these investigators did was they took the antibody that was developed for targeting this enzyme, they used a linker, DFO, and attached zirconium-89, which is one of those positron-emitting isotopes I mentioned earlier. And then they injected this radiolabeled antibody into patients to see if they could better detect sites of renal cell carcinoma compared to FDG, which, as I mentioned, has a quite variable, like the renal cell cancers have variable uptake of FDG. So what you can see here is that this is a patient who had their primary tumor taken out, and now they have a new metastasis in the right adrenal gland. And what you can see is that on PET, you see the normal brain uptake, you see some normal heart uptake, you see some of the normal kidney uptake, and they're missing the other kidney from the resection. But you don't really see any other abnormalities. This is normal urine activity that the kidney is getting rid of the extra FDG, but you don't see any focal black spots to indicate any metastases. However, when you look at the antibody that's imaging the expression of carbonic anhydrase 9, you can see there are multiple black spots throughout the body that you really couldn't see on the FDG PET. And one of them in particular is this mass. They could see this on the CT, so they knew that there was an adrenal metastasis. And this PET agent shows it very clearly that there's a lot of expression of this enzyme in this adrenal metastasis. But what the advantage of this PET imaging shows is that there are actually other sites that were not identified on the CT. So these are very small. And so those would also be very, these are all in the bone. So they would be usually very difficult to find just on a CT alone. And clearly the FDG PET didn't show them at all. So the advantage of having this PET agent is that we may be able to detect the extent of disease better than we can with our current imaging studies. And then the question becomes, if we have this better information, will that then enable your oncologist or your urologist to make better decisions about what the next treatment step is for your cancer? So right now, we actually are part of a multi-center trial that's run by Telix Pharmaceuticals. This is a multi-center phase 3 study looking at that exact antibody, the girentuximab, that's labeled with zirconium-89. It's called the ZIRCON study. And the company is actually looking at the first question, what I mentioned, which was, if you have an indeterminate renal mass, and it looks like it could be not be benign, but it could be malignant on MR or CT, will this PET imaging agent help us determine whether that renal mass is actually cancerous or not? And the potential benefit of this is that then if we can identify with confidence that that renal mass is not a cancer, you can be spared the surgery to find out if it's a cancer. And so Dr. Gore and several of the other urologists are actively recruiting to this study, and Dr. Tykodi and Hall are also on the wings looking to see how this evolves, and hopefully that we can start expanding the use of this tracer. Okay, the next imaging agent I'm going to talk about is a CD8 T-cell imaging agent. So As you've already heard from Dr. Paul's talks and then Dr. Miller's talk, immunotherapy is just increasingly being used to treat renal cell carcinoma, and there's a lot of great promise in in getting long-term responses with this approach. However, as Dr. Miller already pointed out, a number of patients still do not respond. And the question is, can we use any methods to identify the patients who will respond to immunotherapy or not? CD8 T cells are a specific type of T cell that are actually called cytotoxic T cells. So these are the cells that actually are recruited into the cancers to kill off the cancer cells. But we don't have great methods to detect these cells without a biopsy. And of course, you can go in and biopsy the metastases to see if you're getting T cell infiltration. But of course, besides just having to go through the biopsy itself and all the side effects or potential adverse events related to that, you can't biopsy every single metastasis if you have several metastases. It's often not practical. So is it possible to use the question is, can we use an agent like this to identify patients who are responding to justify continuing the treatment early, or identify who is not responding earlier so that you can then switch to a more effective therapy earlier? So these are initial images with the CD8 T cell imaging agent. This is a mini body that binds to a marker that identifies CD8 T cells, and it is also labeled with zirconium-89. And these are initial images from their phase 1 trial, where they basically imaged a number of patients. Now, these are patients with melanoma who were getting immunotherapy. And what you find is that, so this top, I'll point you to panel B here on the left of your screen. You can see there's a lot of normal uptake in the marrow because that's where lymphocytes come from. So they come from your marrow and they come from your spleen, which is why there's so much activity here. But what you find is that normally you do not have lymphocytes in the muscles. And so they found this uptake in a patient who is being treated with immunotherapy, and it was an unsuspected metastasis. They didn't know about it. When they repeated a PET CT to confirm whether there's a real finding or not, there was increased uptake with the FDG. I apologize, my arrows got mixed up a little bit. But this is FDG uptake in a melanoma, and melanoma is pretty FDG avid, meaning it takes up a lot of FDG, so usually we can see it. And then they biopsied this and confirmed that it was in fact a metastasis that they had not suspected. But the imaging would suggest then that there was CD8 T cell recruitment into that metastasis, and the hope is that that would then predict that the metastasis would be adequately treated. This is another example of a patient with liver metastases, again, showing very high levels of CD8 T cell recruitment into these metastases. So we actually we are part of this multi-center trial as well, where we are evaluating the CD8 T cell PET tracer in patients with metastatic solid malignancies, and renal cell carcinoma is one of the accepted cancers that can be imaged on this study. Unfortunately, because the trial is ongoing for both of these trials, I wasn't allowed to share the images. I really wanted to show you what they look like, but with regard to the preliminary results from this particular study, we are seeing increased uptake with the PET tracer that actually correlates with increased T cell recruitment into the study. One of the requirements of this study is that the patients who are getting immunotherapy get a biopsy while they're on treatment, and then a core lab is counting how many lymphocytes are being recruited into the T cell, into the cancer from the biopsy specimen, and then we are looking at that with the PET tracer. So we are seeing promising results so far, and so we're hoping that when this study wraps up, we will continue participating with this company's next multi-center trial that will focus on looking at outcomes in terms of responses. So this study is focused on the correlation between are there lymphocytes that we can see in the biopsy that correlate with the PET uptake? And then the next study will look at do those lesions that have uptake of the PET tracer actually respond? Finally, I will talk really briefly about PSMA PET imaging for renal cell carcinoma. I will say right now is a really exciting time for nuclear medicine because we've had a lot of new different diagnostic PET tracers approved for various different cancers. So that includes breast cancer, neuroendocrine tumor, and prostate cancer is the most recent one to get its own new special PET tracer for imaging. And PSMA PET tracers are quite sensitive for prostate cancer, far more sensitive than anything else we have for prostate cancer, because prostate cancer is actually somewhat in a similar boat with renal cell carcinoma. Prostate cancers don't take up a lot of FDG, and so we've struggled with trying to get a good handle on the complete extent of prostate cancer in these patients. It turns out that PSMA, as I mentioned, is actually highly expressed also in renal cell carcinomas, and from what we can tell, it's mostly based on the fact that there is a lot of new vessels forming, and just as Dr. Miller showed with his CHIP system, the renal cells tend to induce a lot of formation of new vessels, and that's where PSMA is expressed. And so in the clinical trials that they've performed for prostate cancer, they've observed that patients with renal cell carcinoma also have high levels of PSMA, more so than FDG. So there, and I will say PSMA PET, there are 2 agents that are already approved for use in prostate cancer right now. And so I think renal cell carcinoma is going to be one of the next areas that it gets, that this is evaluated for. And the other area is probably hepatocellular carcinoma, because that also is in the same boat, not very FDG avid, but it does take up a lot of PSMA as a result of the new vascular formation. So this is an example of a patient with renal cell carcinoma, clear cell, with 2 lung metastases. And what you can see is on the FDG PET, you can see there's uptake. It's not as dark as those other, the other example image I showed earlier. So there's, mild to moderately increased uptake. It's very similar to the liver in intensity. It's easier to see in the lung because the lung doesn't have a lot of background, but you could imagine that if that was a liver lesion, you wouldn't be able to see it very well. In terms of the PSMA, you can see that it's much more avid, and I realize this windowing is not perfect for this, but this is actually more intense than in the liver. So if this were in the liver, you could see that. And actually the smaller lesion is much more avid than you can see in the smaller, than on the FDG PET. And another potential area, so besides just seeing where the metastases are better, another potential application is looking at response. So, and one of the areas where it is very hard to determine response is in bone. So when a metastasis goes to the bone, it causes structural changes. So you can see in this vertebra here, you can see these lower density areas and this higher density around it. So the cancer cells tend to eat away the bone, causing that lower density area, and then it causes the bone to react around it, which is the more dense area around it. The problem is when you're looking at CT, it's very hard to see if the cancer cells are actually active or not, because once the bone starts reacting to a metastasis like this, unless the metastasis is actually actively growing and you see a change, you can't see if it's responding. So say you get a phenomenal response to your bone metastases, but the CT will just look the same. It won't change, it won't decrease because the bone has already been destroyed, and so the bone doesn't recover and make itself normal again. And we have the same problem in MRI. Once you see a bone metastasis, if it responds, it's very hard to tell how well it's responding. So another potential application is looking at PSMA, where this is a patient who received radiation therapy to this bone metastasis, and you can see that over the 3 and 6 months after the radiation therapy, it's starting to lose its PSMA expression. So the blackness has obviously decreased, so now there are a few sites of that really dark uptake or really high level of uptake, and then it's continuing to decrease. So that, and so this is really promising for potentially looking at response better. Finally, with radiopharmaceutical therapies, I actually focused on PSMA just because we are about to have our first PSMA radiopharmaceutical therapy approved for prostate cancer this year. But the carbonic anhydrase 9 antibody that I showed you earlier, that can also be labeled with lutetium-177 or other therapy isotopes and actually be used for therapy as well. And so you can see that when you have increased uptake, I'll just go back to that image really quickly. So you can see that because there's so much intense uptake on the PET, that tells us that if we give a therapy isotope, a lot of that drug is going to go to that metastasis, and we can deliver the radiation in a very targeted way to the metastases. So radiopharmaceutical therapies for renal cell carcinoma, are they on the horizon? I think a number of centers are going to be starting to look at that as well. You'll see the term theranostics to refer to this. This is when we have a paired diagnostic or imaging tracer and then a therapy radiopharmaceutical. And when you have these radiopharmaceuticals, they're exactly the same, and you're just switching out the radioactive isotopes. So that's what makes it really nice to use PET to see if the tumors are going to have uptake with that particular drug. And then if they do, we can swap it out for the therapy isotope and then deliver the drug to treat those metastases. So as I said, for the field of nuclear medicine, I'm super excited about getting lutetium-177 PSMA approved. Those results were just published. And this is just an example. No one has tried this in renal cell carcinoma, just so you know. So the theory behind this is all based on how it looks on the PET, that we see a lot of uptake in renal cell carcinoma metastases with this. And so the theory is that we should be able to deliver the radiation in a targeted way, but there's a lot of discussion about that. I just haven't seen anyone open a clinical trial yet. I think because most of the companies are focusing on getting this first FDA approval, and once it's approved, then they will probably start looking at other indications. This is just another example showing a patient with prostate cancer, and again, showing the potential for the PET then to also show response. So you can see that there's a very small metastasis here in the right pelvis. That node is probably right around maybe a centimeter, even smaller. And they gave this patient the lutetium-177 PSMA, and they saw a marked decrease in the uptake. And so when you get to these really small lesions, so aside from the bone, if you have a 5 millimeter node, that's also very hard to see if it's responded or not on CT, because it might decrease to like 2 or 3 millimeters, but that's not a few millimeter change is not always enough to know if that is a real change or not. You have to use really thin slice CT to be confident that that change is just not a technical issue with the CAT scan, and there are other factors that go into that. And so there's value potentially in looking at PSMA as a potential marker for whether that metastasis responds or not. So we do have an open clinical trial for imaging prostate cancer using gallium-68 PSMA-11, and I think this will be an opportunity for Scott and John and I to talk about whether there may be an opportunity to look at this in renal cell carcinoma. So I'd like to thank everyone. I mean, all the research that I've been able to start in the last couple of years hasn't been possible without our nuclear medicine team, particular research team, Missy, Zach, and Amanda, our nuke med techs. Scott and Shalender on the melanoma side have been super helpful with medical oncology. Evan Hall as well. They've been helping to recruit to these studies. Evan Yu is the medical oncologist who's collaborating on the PSMA PET. John's group with Atria and George and Dan have all been helping as well. Dan is the director of the Institute for Prostate Cancer Research, who's really helped us launch our PSMA PET, and then our industry sponsors for Telix and Imaginab, who helped us open those multi-site trials and make those imaging agents available here. And we're really hoping to expand. As I said, I just started here. We're hoping to grow the team and grow the amount of the research that we're doing. I think there's a lot of opportunities for looking at this in kidney cancer. So thanks so much for your attention. Thank you again for the invitation. I'll be happy to discuss questions.
Delphine, thank you so much. That's fascinating. It's always wonderful to see the actual image pictures as well and see what you see. A couple questions for you from the audience. What is the resolution of theranostics?
Yeah, so that is a tricky question with PET because it depends on a couple things. It depends on how much of the agent that we're giving, the PET tracer, how much of it actually gets taken up by the cell. Is it just one cell with a tiny bit of expression? We might not see it, but if it's a single cell with like thousands and thousands of receptors, we might see it. It also depends on the scanner itself, the physics of the scanner. So we actually have at SCCA and at UW, we have like probably the most sensitive and the most cutting edge PET-CT scanners available right now. It's called digital PET. So that means we can resolve these 2 and 3 millimeter metastases. So in that clinical trial with PSMA PET, what I can tell you is that we've been able to confidently identify prostate cancer metastases in nodes that are about 3 millimeters. So that's really impressive, way better than our prior or older PET-CT scanners. And so, you know, but then the downside of that is that there may be low expression. And so sometimes we may not see those single cell metastases in nodes because there just might not be enough. So that's why there's not a really good size that we can give all the time that says, okay, we can detect this size 100% all the time. So it's more of a gradient, and in terms of the it just depends on the tracer, and at this point with the scanners that we have, it depends on the tracer and how well it binds. So that's why we're really excited about these super sensitive tracers. Oh, in therapy though, if there is binding, the therapy, even if we can't see it, the therapy will go there. And so the experience in neuroendocrine tumors is that lutetium-177 dotatate, which is the therapy pair of the theranostic agent for neuroendocrine tumor, that is in theory better for smaller metastases. And so because of how the lutetium-177 energy is deposited. So again, there is a balance between what we can see and what we might see, that's why we use biochemistry, like blood levels, and we use multiple different pieces of information the oncologists do to decide whether something is working. And it's not just 100% of the imaging alone, but a lot of it is driven by the imaging.
Great. One more question. The approach seems pretty general. Any comments on using this imaging approach for rare kidney cancers? And if I could amplify on that, you might comment on the CA9 marker and its range of expression across kidney cancer subtypes. And does that contrast with the PMSA marker that might be more generally applicable?
Yeah, so that's a good point. From what I understand, and actually you're probably going to know the CA9 expressions across the subtypes better than I do, but from what I understand, most people have focused on the clear cell renal cell carcinoma, unfortunately, that larger bucket of the subtypes. It doesn't seem to be as expressed as well in the chromophobe, the chromophobe renal cells, which can overlap with oncocytoma. And there's actually a separate imaging agent I didn't talk about just because it's not PET. It's a SPECT agent called technetium-99 and sestimibie. Sestimibie is actually used a lot for heart perfusion, but it actually is also used for distinguishing clear cell renal cell carcinomas from oncocytomas. But the problem is it doesn't distinguish like chromophobe renal cell carcinomas from the oncocytomas because they have similar biology features. And I think the same problem, we're going to run into the same problem with carbonic anhydrase 9. So, I mean, does that jive, Scott, with your understanding of the biology there?
Yeah, so the CA9, going back to Monty Powell's talk, it's a HIF-driven protein. And so it's very intimately linked to the biology of clear cell and the von Hippel-Lindau disruption. Mm-hmm. Excuse me. So it's very much of a clear cell RCC marker. And it probably wouldn't work well for the other non-clear cell subtypes. Yeah, so a more general marker, I know PMSA might be more non-specific. If it's more about, the vascularity of the tumor, that might cut across more broadly all of the different subtypes.
Yeah, I agree with you. And that's what I was kind of thinking when you made the comment about would PSMA maybe be more applicable for across the subtypes, because it is non-specific in a sense. It is just imaging the neovasculature. But if they're all hypervascular, then we should be able to see them. So, but those studies just haven't been done. Obviously, not as many patients have those, and so they haven't come across them as much in the PSMA PET clinical trials. But I think that's something that should be evaluated.
Can I ask you for my own interest? So the Zircon study, the way it's formatted, it's looking at a very discrete clinical question of localized renal tumors. If it's a positive study and that marker becomes commercially available, are you limited in how you use it? Or once it's available, can you use it in any fashion that you choose? I'm thinking, in my world, we're going to use it for patients that have metastatic disease. Will we be blocked from ordering that kind of study if the clinical setting doesn't match how the study was done?
It all depends on whether we can get the study covered so the patient doesn't get a charge, for the study. So we are able to do off-label indications for some of the PET tracers that we have available. For example, we can get, like dotatate is taken up by meningiomas. That's not a neuroendocrine tumor, but some insurers will pay for it and we can get the coverage of the off-label indication. So so I think it's all going to be a matter of like, can we get, CMS, for CMS, like the local Medicare contractor also makes the decision coverage for oncologic tracers. So it's possible if we work with our local contractors to convince them that it needs to be covered, then that's a possibility, even if the national coverage determination is that it's not covered and it's only covered for the specific FDA approved indication. So there are two parts to that, right? It's the FDA, what FDA approved indication are they going to get? And then what is CMS going to cover? And it tends to follow the FDA approved indication, but they may, we'll see if they have any plans to go forward. I have a feeling Telix is probably going to try to get that indication first before they expand, but at the same time, they're pretty, every company I know of is always looking for broader indications for their tracers. And so I am sure that's like a natural next step for them.
Yeah. We're a little over, but we're just spilling into our Q&A time. So one last question, if you don't mind.
Yeah.
The PMSA imaging you showed looked to me like there's a lot of uptake in normal tissues. So the idea of using that as a therapeutic to deliver targeted radiation is a little bit uncomfortable. What's the toxicity to normal tissues that you deliver with that kind of approach?
So it's still, what's interesting is that because all of our tracers, almost all of them go to the liver and spleen, like that just is a common feature of all of them. And then there's variable uptake with pancreas and then, but when you're delivering a therapy, what we worry most about is the, here, I'll just pull up the image really quick, actually. So marrow is the first thing that we'd worry about because the marrow cells are very sensitive to radiation, no matter what, even if it's not being taken up by a lot of, even if a lot of the drug is not actually going to the marrow. Let's see, okay. And then the next thing we would worry about, so you can see like the bowel stuff, there may be some toxicity that's hard to predict. There may be some liver toxicity, but because of that high delivery to the spleen and marrow, we always worry about that and that will drive the dose. So far, the trials with the lutetium-177 PSMA for prostate cancer patients has actually been quite well tolerated. But the other thing you can see is that there's a lot of normal uptake in the salivary glands and the lacrimal glands, your tear ducts. So we worry about whether you'll get dry mouth as a result of that. And excuse me, with lutetium-177, it doesn't seem to be as toxic as radioactive iodine. So I-131 or radioactive iodine is another common isotope for therapy, but the energy delivery for I-131 is a little farther than lutetium-177. And it does have some higher energy emissions that seem to be a little more toxic. And then radioactive iodine itself can come off of the drug and then go to the salivary glands just by itself, even if it's not part of the drug. So, so we do worry about the salivary gland toxicity. And I will say that there are actually drug development efforts now to tweak the PSMA molecules to reduce the salivary gland targeting so that they can reduce that toxicity. But from what we've seen so far, it's probably going to be marrow and salivary gland toxicity that will be really the most bothersome and concerning for patients.
Excellent. Yeah, I love seeing the pictures. Well, Delphine, thank you so much. That brings a close to our scheduled talks. But Dr. Gore and I are available to stay around to answer any questions or until 1 o'clock, whatever comes first. I don't see any posts yet, but there's still several people online. Oh my. Well, Dr. Gore, you've got some reading to do here.
I'm going to do a quick chart review here. I removed Michael's right kidney in October of 2019. His hypertension was controlled until testosterone replacement therapy was started in March of 2020 because his testosterone level dropped to low levels. Since the testosterone therapy, he's had some weight gain and the blood pressure is not really well controlled. Enlarged prostate is not really well controlled. And the PSA is going up. From the left kidney, the renin has been elevated. He's tried a bunch of different therapies for the high blood pressure. I would say, you know, a lot of the symptoms that you've been having since starting testosterone replacement therapy are things that we can associate with testosterone replacement therapy. It may be worthwhile to see an endocrinologist who has more experience with testosterone replacement therapy. I work with John Amory a lot at our Men's Health Center, at the UW Men's Health Center. And I think he would be potentially a great person to connect you with. But I do think taking a break from testosterone replacement to see what happens with some of these symptoms would probably be a really good idea. Any other questions or comments? So this is a great question, and I would love your perspective, Dr. Tykodi. Oh, and by the way, there's no Men's Health Center at UW Smoky Point, but you know, I can look into see what providers are there. This person had a total left nephrectomy in 2014. It sounds like for pathologic stage 1 kidney cancer, and has been cancer-free since that standpoint. At this point, 7 years later, what are the odds of a metastasis magically appearing, Dr. Tykodi?
So that's a great topic, and I'd be curious, John, your opinion too. You know, current surveillance guidelines, there's NCCN, which is probably the most widely cited, but American Urologic Association has its own guideline documents as well. Stage 1 kidney cancer, the typical recommendation is a 3-year duration of surveillance, stage 2 and 3, 5 years. I was very impacted by a study that was reported a few years back now from the Mayo Clinic campus. They retrospectively looked at their experience going back to the late 70s up until whenever the paper was published, mid-2010s. Over 3,000 total patients, and the implication of the paper was on their campus, they didn't stop surveilling patients. So they asked the question, what was the catchment of the 5-year recommended duration of surveillance when they knew the final outcomes for all their patients? And the answer was the detection of recurrence in that 5-year interval for stage 2 and 3 at least was in the mid 60s, 63, 65%, something like that. So 2/3 of patients, but meaning that fully 1/3 of recurrences were so-called late recurrences happening after the recommended duration of surveillance, which was a higher fraction. I would have guessed up front, it might have been like 85% detection in that 5 years. So missing fully 1/3 of recurrence is a little bit unsettling. That being said, the absolute chance of recurrence for stage 1 is only in the 5 to 10% range. But for my higher risk patients, stage 3 patients, I routinely offer patients the option of extending beyond the 5-year interval. I offer them the option of going out to 10 years. but I do amend my, my screening beyond year 5. I do full body imaging with CT or MRI up to year 5. From year 6 through 10, I dial it down. I do a plain chest X-ray and abdominal ultrasound. And the rationale there is to reduce the radiation exposure to patients. I looked this up once, and the number that sticks in my head, I may be way off, Delphine can correct me, but a plain chest X-ray was 1/40th the radiation exposure of a full body CT. So, you know, less negative component to the screening, but still watching and still monitoring to some extent for any new findings out to year 10. And then I would discontinue completely beyond year 10. And that's, you know, that's not codified in the guidelines, but that's what I've adopted because of the Mayo Clinic data, recognizing that's the only, you know, it's a single center experience, and is that ubiquitous to everybody? I really haven't seen other large centers, you know, Sloan Kettering or Dana-Farber or somebody else do the same analysis and report the data. Maybe nobody can, because maybe nobody scans people forever like Mayo Clinic does, so they can't really ask that question. But I think it clearly generated a lot of discussion in the field after that data was presented, but it didn't move the bar in terms of NCCN or AUA changing their formal guidelines. John, what's your thought on surveillance?
I mean, I think you and I are very concordant on this, and I misinterpreted the P1. So the P1 meant that this was a papillary type 1 kidney cancer, and the stage was actually a stage 3A. And so this is one of those cases where, as you said, I would discuss extended surveillance based on that same Mayo study. And it came out in the Journal of Clinical Oncology and influenced a lot of us in how we think about surveillance. And so typically, if it's a stage 1 or a stage 2, I would follow for 3 or 5 years. But if it's a stage 3, I would follow that for an extended period of time, out to 10 years. And so I would keep going for a couple more years. Now, how many of those cancers are found, those recurrent cancers are found after 10 years? That number drops off very precipitously, very precipitously. So I think 10 years is a pretty fair endpoint.
Yeah, I think in the Mayo data set, 10 years gained you, I'm certain it was above 90% of all recurrences. They had a few very late ones. Their all-time longest was, I think, 14 years. I've actually seen patients in my clinic at 17, and I have somebody that I think recurred more than 20 years from first diagnosis. But from a public health resource utilization standpoint, you really can't hold to 100% catchment of anything. But I feel like at the 10-year landmark, it looks really good when you look at the Mayo data.
Dr. Tykodi, are there any upcoming trials that our patients who are listening in on this seminar should be aware of?
So I think, yeah, as a takeoff from Dr. Pal's talk earlier, a question I had for Monty, but we were running short of time, was, and he did address this to a degree. You know, right now the field is littered with all these 2-drug combinations that are very, very similar to each other. And there's some nuances choosing between them, but there really isn't a right or wrong. But what's going to move the bar and what's going to move the field off of the doublets to something that's even better? So on our campus, we've had studies. One that has enrolled completely, but is certainly still ongoing, is a 3-drug therapy, 3 drugs that are all available. So it's not bringing something brand new to the mix. But ipilimumab, nivolumab, and adding cabozantinib to that as a 3-drug combination. We have another 3-drug combination that's open right now. That's nivolumab, cabozantinib, again, a standard 2-drug combination. The 3rd drug is a novel compound that's investigational. It's a novel cytokine drug called bempegaldesleukin. So looking to see if that 3-drug cocktail is provocative. It's a phase 2 size trial, meaning it's unlikely that the trial itself would gain an FDA approval, but would be a stepping stone to go forward with a larger study to prove it's better than a standard combination. The other compound Dr. Pal made reference to, I call it belzutifan. He said belzutifan. He pronounced it a little bit differently. I'll have to ask Merck what's the proper pronunciation. The oral HIF inhibitor that is in clinical development, that is going to be incorporated into frontline trials as 3-drug combinations on top of 2 drug combinations that are already standard. So, you know, a different add-on, a targeted add-on rather than an immunotherapy add-on. But there'll be several of these 3 drug combinations that may, you know, if they're all positive, it'll clearly change the field, or if one of them is clearly positive. So I think we, you know, may evolve into a world of 3 drug combinations that might even have competing options for that. Behind those drugs that are making it into phase 3 trials, there's not a lot that is catching the field's attention in terms of early drug development and some new pathway or some new compound. So I think things may fall off a little bit. Although I am very excited, I share Dr. Pal's enthusiasm about the potential for cellular therapy. You know, the Fred Hutch campus and SCCA, we're a huge cell therapy center. You know, one of the largest experiences in the world for bone marrow transplant, which is a cell therapy, and probably one of the largest clinical programs now in the emerging world of autologous cell therapies, engineered T cells that are CAR T cells or TCR T cells. But I have to say, very disappointingly, for a very, very vigorous, robust development clinic, physical space to treat these patients, we have, I think, approaching 20 plus open clinical trials across the spectrum, both blood cancers and solid tumors. Not a single one is enrolling kidney cancer patients, which is really stunning because historically kidney cancer has been considered a very immune responsive disease along with melanoma. And so why kidney cancer hasn't come forward, at least on our campus, as being a target for some of the development compounds, I think has a lot to do with the absence of good targets on the tumor that people feel comfortable pursuing with these compounds. But as a program, we're very, you know, excited about the prospects. We're certainly looking for opportunities, either companies with compounds coming forward that we can be part of a larger experience, or even from our own campus. Dr. Miller made reference that a colleague of mine, Hudi Warren, has as a laboratory investigator and has done T-cell work with compounds that have interest for clinical translation. So there could even be something that comes forward from our own campus as a unique therapy. So I'm hopeful that that bears fruit down the road, but it's not the here and now. We don't have any open studies at present.
Dr. Tykodi, what about new vaccines? We obviously have a shared experience with a vaccine trial. Are there any new vaccines based on, you know, some of these specific proteins we talked about today that might trigger more specific immune responses?
Yeah. At a high level, the 30,000 foot level, the world of cancer vaccines is really expansive. You would be surprised how many studies have been done with cancer vaccines going way back to the 1990s. And horribly, horribly disappointing that these haven't borne fruit. From the discovery of how the immune system actually sees targets and understanding what are the molecular targets the immune system uses to recognize target cells, the belief was you could then manipulate that and create vaccines for cancer. And again, literally thousands of clinical studies, and virtually all negative. The current wrinkle is the insight that the mutations in tumor create unique protein sequences that the immune system seems to detect preferentially, what are called neoantigens in the field. And so there's a whole new wave of trying to build cancer vaccines specifically targeting these so-called neoantigens. The disconnect for kidney cancer is kidney cancer doesn't other diseases like melanoma and lung cancer. And when you look at the big data sets with the checkpoint drugs, it doesn't seem like the mutation burden is an important factor that's contributing to the likelihood of response. So it's not clear that the neoantigen work is going to be successful in renal cell, where it may be much more successful in other diagnoses. So there's not right now a whole lot of cancer vaccine development in the kidney cancer field.
Here's a question about how often spread of cancer is found outside the chest or abdomen, and why we don't do more brain or bone scans. This is a person that's had surveillance chest and abdomen scans for stage 3 kidney cancer. I would say it's fairly darn rare. I'm actually a member of the American College of Radiology panel on genitourinary imaging. And so we look at the benefit of a lot of these scans, either in the early staging of a newly diagnosed kidney cancer or in the surveillance of kidney cancer. And it's very rare to have spread of kidney cancer to the brain without any other manifestations in the chest or the abdomen. If someone had symptoms that were indicative of something unusual happening in the brain, we would definitely get imaging at that point. And bone scans, we tend to use differently as well. As a staging study for someone that you don't suspect has metastatic disease, we rarely use them, but it's pretty common that we use them in people that have other metastatic disease just to look at the bones. Dr. Tykodi, do you have any comments about that?
No, I agree. And John, you'd be the best voice. You sit on the NCCN panel. It's a public health resource utilization concept. When is something at a low likelihood that is decided it's not valuable, and realizing that's a very subjective call, to include those scans comprehensively in all patients at all times. And, of course, if it was me and I wasn't offered a brain imaging study and then I had brain mets, or I wasn't offered bone imaging and then I had a spontaneous fracture of my femur, I would be bitter, because I'd feel like, that should have been known or looked at. And I appreciate that disconnect, but you have to have a reason about what you look at. You can't look at every scan in every patient at all times. And so there are guidelines that are intended to be thoughtful about how these are applied, and it is based on likelihood. But it's, again, when it's a personal experience, it doesn't feel good.
And I think a related question, how do we decide when PET is used? Similarly in that panel, we've reviewed PET scans for staging of kidney cancer, and it's felt that for conventional staging and identification of metastatic disease, PET scans are not better than regular CT imaging. But in the context of something like Dr. Chen discussed, in the context of a clinical trial, that's where it has benefit.
Yeah, I think Delphine highlighted that the FDG glucose tracer, that's the commonly used one, is not always a faithful marker in renal cell, although it's not bad. But I can tell you from a very pragmatic standpoint, insurance companies have a list of approved diagnoses for PET imaging, and renal cell is not on that list. So it's very frequently denied as a requested study. And then you have to go back and forth and appeal and try and convince the insurance. So it often just becomes a boondoggle of time and energy. So there has to be a really important clinical gain. And often it's not clear what that would add on top of what you know from your CAT scan or MRI scans.
Dr. Chen, any additional comments?
I was just going to say, it is unfortunate that the PET scans it seems harder to get them covered here than at my prior institution. And so it's unfortunate, because I think the area where PET might be the most useful in this setting is when you have an aggressive metastatic cancer that you're trying to figure out, you're monitoring them more closely, and I would say that's not even something, we didn't see that very commonly at my prior practice either. But if we did use PET, that was usually the most common situation, was they've got an aggressive tumor, they want to monitor them closely and make sure that they catch, whether there's response or not, or early progression as they're continuing with therapy. But yeah, I appreciate Scott's point about it can be a challenge to get them covered here, it seems.
Dr. Tykodi, you're a perfect person to ask this. Any IL-2 related new clinical studies?
Nothing real new. We actually have a site unique study that combines IL-2 with pembrolizumab, which is called Keynote. So it's unique to our campus. IL-2, if people are familiar, requires inpatient care, and actually you're in our oncology ICU at the University of Washington. And when the pandemic broke last year, there was, obviously grave concerns about overloading hospitals' ability to treat patients, and particularly needing ICU care. So we stopped using IL-2 entirely to avoid putting patients into the ICU. So it's been a casualty of the COVID pandemic, both routine IL-2 use and our clinical trial. We deliberately avoided using them. Things are obviously much better in July of 2021. So we are intending to bring that trial back online and it should be active. But from a practical standpoint, it's sponsored by the maker of pembrolizumab. And, we keep explaining to them we can't control the pandemic and we haven't been using the trial for, a year and a half, but they look at a trial that's dormant and that's not active and they're threatening to withdraw the support. So I fear that study's going to come to an end at the end of this calendar year as a casualty of COVID, unfortunately. But it should hopefully reemerge for at least a few months and be available this summer.
Dr. Tykodi, do you have any thoughts on, the discussion about the intersection of the microbiome and kidney cancer therapies that Dr. Powell mentioned in his talk?
Yeah, it's that was a highly noted data set at ASCO, even though it's a very small number of patients. It's, Dr. Powell didn't really have time to do justice to the field of the microbiome. This is an area that is clearly impactful biologically. There's all kinds of correlative observations that what's in our GI system impacts our bodies, and particularly our immune system. Taking antibiotics seems to undercut the activity of the checkpoint drugs. But the big unknown is, if you're convinced the microbiome is meaningful, can you manipulate it to your advantage? And so his group has been one of the first to actually try and do that with a probiotic supplement and see if it makes any difference. And the early data is really provocative that the treated patients looked really, really good in their success. But again, it's a very small study. But it's certainly the hope is that you can manipulate the microbiome to your advantage. With something as simple as an oral capsule would be fabulous. People are looking at doing so-called stool transfers in a more cumbersome, complex strategy of reseeding the bowel. GI specialty doctors doing a more complex, I'm not sure if they do some kind of conditioning to try and eliminate as many bacteria as possible, but then having a donor that provides their own bacterial composition, that would be, of course, very complicated, not just a single capsule, and reseeding the bowel. So those kinds of strategies have a niche in certain medical conditions, and whether they'll make an appearance into the oncology world isn't known, but it's being looked at actively. I know that some of our colleagues in the GI program are trying to develop those kinds of clinical opportunities on our campus. There's nothing here and now, but hopefully in the next year and a half, we have some opportunities like that.
What about, obviously there's a lot of talk about the COVID vaccines. What about therapeutics based on messenger RNA?
So that technology, the Moderna technology, is already here and now. We have an active cancer vaccine protocol on our campus that uses the mRNA and the nanoencapsulation formulation. But again, it's a neoantigen focused vaccine compound that's enrolling melanoma patients. I don't know if kidney cancer is eligible, but we haven't, again, been aggressively looking for that because the data doesn't really lead us in that direction. But that does actually cross over to the cancer arena already.
And then we have a question about ultrasound. So we talked about PET imaging, we talked about CT, and the question is, should we be recommending essentially screening for kidney cancer with ultrasound? So actually, there's this thing called the Effective Healthcare Program that a division of the NIH runs. And they try to look at the evidence for a lot of different topics in healthcare. And they looked at this in kidney cancer. So what is the benefit of screening in kidney cancer? And they were unable to find that a screening strategy based on imaging, including using ultrasound, that would not be a very cost-effective strategy. Ultrasound is really great at monitoring just the kidneys. And so, for example, I use ultrasound a lot in doing what's called active surveillance of kidney masses. So people have a small kidney mass or a kidney mass that we think has a good chance of being benign. We just watch it, and ultrasound is a great technology for that. We use ultrasound a heck of a lot less for monitoring for the development of metastatic disease or in early diagnosis, in part because it's really great at looking at the kidneys. It's not as good at looking at some of the other structures around the kidneys that we care about when we look at staging of kidney cancer or surveillance of kidney cancer. So that's partly why it's not more universally used.
John, and I see Lauren is still signed on. So what about the world of the syndromic patient? You have a family member diagnosed with kidney cancer and they have a positive gene association, and you're tested and you're a carrier. What's the surveillance strategy for that person that now has a massively increased risk of developing kidney cancer, but is currently cancer-free?
Lauren, do you want to pop on and take a first stab?
You guys
Or
hear
I'm
me
happy.
okay?
Yep.
Okay, perfect. Sorry, I closed my laptop, so I don't have my video up anymore. But essentially your question was, what's the surveillance approach for patients who are at an increased risk for renal cell carcinoma? It depends on each specific genetic change that we find. So it's going to look different for a patient with Birdhog-Dubé versus a patient who has HLRCC. Sometimes they do use MRI, sometimes CT. I do kind of leave that up to Marianne and her discretion, and then also the frequency. Sometimes it's, every 1 to 2 years, sometimes it's every 3 years, but really I do kind of leave that decision up to Marianne, and she kind of factors in a number of different things, including not only the specific genetic change, but the family history, the current age of the patient, and kind of goals, etc.
So that's interesting. So is ultrasound not considered an adequate screening tool in a person that stands at a very high risk of developing incipient kidney tumors?
I've heard about people using ultrasound, but I'm not quite sure. Just because I see so many affected patients and not so many patients who are unaffected, I can't really tell you. I'm sure it's used some places, but like when I look at NCCN, I think MRI and CT are kind of mentioned more often. But yeah, to be honest, I see so many affected patients and not many unaffected, so I'm a little out of the loop.
So John, I think, syndromic families probably get handed off to urology for monitoring. So you would be the person that would be seeing these people. What's the strategy?
We use ultrasound a lot. The settings are definitely syndrome specific. And so, for a syndrome like von Hippel-Lindau, where there is a risk of other additional intra-abdominal findings, like you're worried about monitoring for pancreatic neuroendocrine tumors, for adrenal tumors like pheochromocytoma, then we use CT or MRI a lot more. For syndromes like Birdhog-Dubé, where the intra-abdominal manifestations are really limited to the kidney, we use ultrasound a lot. We have a question in the chat, and I'm going to ask this of you, Scott, because this patient would probably see you for this question. An initial nephrectomy in 2005. This kind of speaks to this idea of how long follow-up is enough, but had a metastasis removed from the stomach in 2019 and is now wondering about monitoring. So use of follow-up PET scans, how effective are they going to be at detecting for recurrence? They've had endoscopies to monitor for recurrence, which I think is a very important adjunct, but what would you use as a strategy for follow-up in this setting?
Hold on, I've lost control of my window here. So recurrence in 2019 in the stomach. Okay, so metastatic disease in 2019. So metastatic, but NED, presumably all the cancer's been removed. I would reset the clock to time 0 with the new finding and, resume surveillance, but with a shorter interval at the outset. I typically do every 3 or 4 month imaging the first year. I do every 6-month imaging beyond year 1 to year 3, and then annual imaging to year 5. That mirrors NCCN, but that's based on localized disease. But at least to provide some context for the frequency of scans. But that's a person that, I wouldn't sign off at year 5 for sure. I would advocate we continue forward with additional imaging. I guess the question is whether to convert it to the lower sensitivity chest X-ray ultrasound or leave it as cross-sectional body imaging. The data for resection of metastatic disease in patients, it's not nearly as good as localized disease. The risk of recurrence in broad strokes, 80-85%. There's some fascinating data that breaks it out by the site of the metastatic lesion, that there's heterogeneity in the risk of recurrence depending on where the lesion was. I usually don't dive down quite that deep. But the fear is that if you're healthy and live long enough, you're going to see the cancer again. So I wouldn't sign off for surveillance probably forever. I suppose if you get way, way out there, 10, 12, 15 years at some point, you might call it quits, but not anytime soon.
Yeah, and I'm going to comment super quick because I saw there's in that same question, there's a how effective is PET for showing a new blockage, which would inhibit an upcoming capsule endoscopy of the small intestines. So just so you know, like PET is not going to be great at showing obstructions per se, unless there's a large FDG avid tumor that's causing it. And so if you're worried about how effective your capsule endoscopy is going to be, that it's not a question that you would get PET for. Usually the question you're asking when PETs are ordered is that, are there other metastases that you're not suspecting that you want to, but you're considering targeted, like local metastasis directed therapy as opposed to systemic therapy or something like that. I mean, as a general cancer question, that's the situation where PET is most commonly used. So in terms of an obstruction, it probably would not be the first test to look for that.
Looks like we're out of questions. I was going to give it 1 second and then hand it over to you, Scott, for our outgoing message.
Yeah, just reminders to everyone that's still online that Ritu, she posted in the chat, but she'll also be followed by email with a feedback link, and we would certainly be delighted to hear good or bad things so we can try and optimize the program for subsequent years. And we really love suggestions for topics people would like to hear about. We can always try and figure out a way to align people on our campus and our faculty. The Zoom format is lovely, and our ability to reach out nationwide and even worldwide to bring in experts on different topics to be part of the program. It's hard to know where we'll be a year from now, if there'll still be COVID issues and if we'll still be doing virtual. I'd say, unfortunately, odds favor that may be the case. At some point, we would like to go back to in-person meeting. But I think people have become so comfortable with Zoom. It is a lovely format, and it does have the advantage of pulling in people from quite a wide range and giving us access to outside experts. And so we'll have to see what next year looks like. And again, I wanted to give a call out one more time to Ritu Shriyan that did all the doing for this program. And so we're so thankful for her help and her department at SCCA to make this possible. So we're hopeful, we try and make this an annual event and certainly expect to have something in summer of 2022 as our next point to focus on. John, any final comments?
No, gratitude for Ritu, but also gratitude for everyone who gave a fabulous talk today and everyone participating in the symposium. Thank you for all your terrific questions and comments. We really appreciate your engagement and feedback.
John, I see there's another question that's popped in here before we sign off. This really interesting question that has come up in my own practice from time to time, but I really look to my surgical colleagues. The question or the statement was, in 2019, a small kidney tumor was treated by, it sounds like, an ablation procedure without a biopsy. So, on our campus, I think we hand off the ablations to interventional radiology. It's not actually you and your colleagues from urology doing the procedure. But I've seen patients that had ablations without biopsy. I've seen patients have ablation with biopsy. I feel like I would want a biopsy, but yeah, it doesn't. Listen, I'm not sure it makes a difference clinically what you're going to do after the fact. I'm curious your perspective.
Yeah. So if you look at our guidelines suggest that you should have a biopsy before having an ablation procedure, like freezing it or like other thermal therapies using microwave or radio frequency ablation that heat it, that you should have a biopsy first to confirm histology for just this reason. So you can guide how you would manage it. Also, that biopsy might tell you that you don't need to manage it with an ablation and that you can just watch it. But typically, if we haven't gotten a biopsy, I would treat it as a cancer and I would monitor it based on those guidelines, which for me, if you look at our radiologists, they'll do it more frequently, but I would do it, on an annual basis, like a stage 1 cancer.
And what's your perspective on the ablation techniques that are commonly used for the kidney? On our campus, I think we have a preferred strategy, but I assume that any medical campus will just have one technique available. Is that true?
Typically. So we prefer cryoablation. So there is some evidence that it's superior to radiofrequency ablation for small renal masses. It also is less likely to cause injury to some of the internal kidney structures, like damage to the urinary collecting system. We do sometimes use microwave thermal therapy because sometimes we have a larger tumor that we don't think is a candidate for surgery, but we want to do something about it. And that's maybe a little bit better for bigger tumors. In general, ablation is better for tumors that are 3 centimeters or less, because it's hard to get a consistent temperature across a tumor that's bigger than that. But our default at our campus is cryoablation.
But how ubiquitous do you think cryo versus RFA would be across, medical centers in the US?
So one aspect of radiofrequency ablation that tends to make it a default at a lot of places is that you can put one time in the tumor and deploy a field big enough to kill kind of any size mass. Whereas with cryoablation, each needle you put in covers about a 1 centimeter diameter ice ball. So if it's a bigger tumor, you need multiple needles. And that's why sometimes radiologists prefer to do radiofrequency ablation. But it's, more and more, we're seeing more sites default to cryoablation.
Excellent. There's one more comment. This will have to be the end. We're at the 1 o'clock hour. Something that just popped off my screen. Well, thank you, everyone. All of our speakers that are still online. I see Art and Julie are still online. I thought the advocacy portion was excellent. Hope that's valuable to people. I bet a lot of people don't know that there's a local support chapter. So hopefully everyone enjoyed the program today. And again, look for us 2022 for the next go round, maybe in person, maybe virtual, but I think we'll certainly plan to have something. Last year was a big upheaval, but I think there's been a lot of adaptation to the new reality. So we'll definitely have something next year. And thank you, Dr. Gore, for co-hosting. And again, Ritu for doing all the heavy lifting to make this program happen. Thank you.